Good morning, ladies and gentlemen. I, Shriti Sridas, would like to welcome you all to the second day of the International Conference on Mental Health of Children and Adolescents. I feel privileged to extend my warm welcome to all the eminent dignitaries present here today from India and abroad. Therefore, without further ado, I would like to invite our esteemed dignitaries, Dr. Rakesh Kumar Sir, Honorable Chairman of Uttarakhand Public Service Commission, Dr. Sanjay Bhatt Sir, former Senior Professor of Delhi School of Social Work, to proceed towards the podium for the lighting the lamp ceremony. I would also request our distinguished guests, Mr. Y.M. Shamroon, Sir, Executive Director of First Step Cambodia, and Mr. Krishna Kumar Thapa Sir, Director, Voices of Children, Nepal, and Shri Deep Purakashtia Sir, Director of Praja, Kolkata, to proceed towards the podium for the lighting the lamp ceremony. Light symbolizes knowledge and divinity. It not only dispels darkness, but also illuminates our soul. I request you all to kindle the auspicious lamp to embark on today's proceedings. Thank you, sir and ma'am. Now may I request our eminent dignitaries, Dr. Rakesh Kumar sir and Dr. Sanjay Bhatt sir and Srimati Rita Panikar ma'am, to grace their seat on the dais for the inaugural session. Thank you. Now I take this opportunity to introduce our first dignitary. Dr. Rakesh Kumar Sir, the Honorable Chairman of Uttarakhand Public Service Commission, trained as a Doctor of Medicine at All India Institute of Medical Sciences, New Delhi, Dr. Kumar has been serving the country firstly as a physician and subsequently with the Indian Administrative Service since 1992. He was also deputed to the Union Government, where he served as the Joint Secretary, Ministry of Health and Family Welfare, Government of India, as he led the largest reproductive, maternal, newborn, child and adolescent health portfolio globally, amongst other several key assignments. Dr. Kumar was instrumental in establishment of 6 new All India Institute of Medical Sciences in India. He has authored 30 research papers in peer-reviewed journals. He has also served as the advisor to Honorable Chief Minister of Uttarakhand State, expert member of the advisory board to His Excellency, the Governor of Rajasthan State. Now, may I request Mr. Manoj to greet Dr. Rakesh Kumar Sir. Our next dignitary is Dr. Sanjay Bhatt Sir. Dr. Bhatt is a renowned name in social work fraternity. He has received master's and doctorate in social work and law degree from Lucknow University. A highly proactive academician, Professor Bhatt had been the faculty with Delhi School of Social Work, University of Delhi since 1993. He is a social work educator, trainer, and development consultant with his felt presence over more than 3 decades. He has also taught in the Department of Social Work at University of Lucknow, Mahatma Gandhi Kashi Vidyapith, Varanasi, Kurukshetra University, and Chitrakoot Gramodaya Vishwavidyalaya. His interest areas are non-profit organizations, social work education, social legislation, social security, and occupational social work. He has written and edited 8 books, contributed chapters in 12 books, about 50 research papers, 4 monographs, and conducted dozens of evaluative studies for national and international organizations. His thesis on 4 Ws, that is water, work, waste, and women, in development paradigm is widely accepted in academic fraternity. In order to bridge the gap between theory and practice, he has initiated many innovative projects like University for Development Action and Integrated Learning Project for rehabilitation of earthquake-affected persons in Bhuj, Gujarat in 2001, and for relief and rehabilitation of flood-affected people in Supaul, Bihar in 2008. He has served as the president of National Association of Professional Social Workers in India. Now may I request Ms. Richa to greet Dr. Sanjay Bhatt, sir. Thank you. Our third dignitary is Srimati Rita Panikar, ma'am, and she needs no introduction because she's the director of Butterflies. So may I request Mr. Hassan to greet Srimati Rita Panikar, ma'am. Thank you. Now I hand it over to Dr. Sanjay Bhatt, sir, to chair and set the tone of today's proceeding.
This session is to discuss the concept of mental health from the lens of holistic health and well-being. There are so many issues the children are facing, and the stress, anxiety, depression, many mental health issues are not even noticed by the family members or by the school or by the whole environment. Now, with the growing need of the internet has also fastened the entire process of affecting children's mental health, keeping them away from their schools, sports activities, physical activities. I was searching on internet one interesting issue once upon a time, global issues faced by the country, global issues. At one place I find the United Nations has listed 10 global issues. Of course, hunger, poverty, climate change. But there was a mention of child and youth safety. So looking at from that perspective, that UN or global issues recognized by UN and this international conference, the theme of this international conference is a real rejoinder, real response to a problem which has yet to be understood by the states. When I say yet to be understood by the states, children and young persons do not get the same amount of attention, except in terms of providing some welfare services, or probably they do not get much attention because they are not CRC, there has been a little change. And India has witnessed a drastic change. But if you look at the CRC proceedings, especially I will mention a proceeding in 2021, the Committee on Child Rights, Rights of the Children, and its general comment 25. This is available on net also. And if you wish, I can share with you. This is a 125 points report, 21-page report. And it talks about the vulnerabilities of children in the digital environment. And you know that how COVID pandemic has forced us to become more and more digital. We already have problem of children and adolescents going on the internet, surfing them, and gambling, gaming, cyber crime, cyber education. Those issues were there, but not to that extent. There are some studies which have shown that after the COVID, the reach has increased. And we do discuss, but there are not solid preventive or punitive mechanisms. Though we have made some restrictions, like child cannot go and make a account on Facebook or cannot visit some other sites of interaction. But there are many sites which are so easily available, including Facebook. You have to write your age, not less than 18, you will get the account. So when the cyber space is being approached by the children, the cyber space also affects the children badly, knowingly and sometimes unknowingly, knowingly in the sense that market and advertisement world capture this 30-35% population so beautifully that we do not know what is going on. And the model of ACE, anonymity and convenience and escape on the internet world, has basically taken children, vice versa the advertisers and marketeers on that. So my submission is this, that in this session we will listen Dr. Kumar about the children and adolescent and young person mental health, how it is being affected, especially into this internet age and digital environment, and the mechanism which the states have taken to combat with them, which are least. Last word I would like to say, when we examine different stakeholders, one reality is that there is a tectonic shift in the societal values. And our established institution has somewhere becoming defunct. And especially the biggest institution which has beared the brunt of this entire process or entire change in past 20 years is the family. 2-3 years back, I have written to the Prime Minister that we drastically need the revival of family values in this country. Any social problem you discuss, whether it is related to children or whether it is related to the aged people, finally, if you will funnel out, it will come onto the family. That it is the socialization, it is the control of family do not have time, many formats. So I have a firm opinion that if we have to reduce the vulnerabilities of children, we have to safeguard, probably we should need some kind of a large program, and our Prime Minister normally take program in mission mode. So something like national level family health or family empowerment or family enrichment mission, where families has to be enriched and how they can play a better role. There can be many approaches. As a chairperson, I should not go much beyond this, and I'm sure that you will be waiting to listen Dr. Kumar. So he has already been introduced. As a chairperson, I have to request him to go ahead and enlighten on some of the issues which I tried to flag out. Thank you, sir.
Yes, please.
Can we have this door closed? This door can be closed. Or? Good morning, friends. Professor Sanjay Bhatt, very distinguished professor and an academician of very high order. Director of Butterflies, Marita ji. Distinguished participants from different countries, Nepal, Cambodia, Philippines, Rwanda, Guyana. If I've forgotten somebody, kindly pardon me. Other distinguished participants from the country. Well, firstly, I would like to profusely thank Rita ji for inviting me to this, one of the most important, conferences. I always look forward to such kind of conferences, especially if anything is coming up for the adolescents, I'm always there. So thank you so much, and I really mean, I profusely thank you for inviting me to this important conference. Also, I'm deeply impressed for one reason, Rita ji, is that you've organized this conference especially around the mental health and well-being of adolescents and youth. And more so because this is the month, the month of May is supposed to be the awareness month for mental health. This started way back, I think, post Second World War from America. And I think this is a huge opportunity for the country to absolutely, I think India can always, and country like India should always look forward to these kind of opportunities. When we have a month dedicated sorts of, for such kind of endeavors, we should have done, much more, but at least I must place, my compliments on record that you are the person who is organizing this conference around, raising the awareness and around the adolescents and their mental health. Friends, I always say, I said, let me just, put a disclaimer at the outset. I am not an expert. I am a bureaucrat, I have done, quite a lot of policy work within the ministry. I have started in the ministry at a joint secretary in the Ministry of Health and looking after this portfolio also. And I, if I may say, though my portfolio was pretty large, I looked after reproductive, maternal and newborn child health, vaccines, gender and all that. But I think adolescent health was one portfolio and a sub-portfolio, I would say, which, attracted me the most. I don't know for what sort of reasons, but that is something, and that was the time when we came up with a new program, new strategy also. I'm talking in January 2014. Friends, we always say that India is a country of, it's a story of numbers, we all know, but it's also at the same time a success story in the making, for multiple reasons. Independent India started its journey way back in 1947 with a population of 33 crores. Yeah. If you look at, if I cite some sort of data in front of you, our life expectancy used to be just 32 and 33 years, 33 for the female, 32 for the men. Now it is at more than 70 years. If you look at, the mortality data, we used to lose, you look at under 5 mortality, more than 200 per 1,000 live births. Maternal mortality was as high as more than 2,000 per 100,000 live births. If you look at the total mortality, more than 50% of mortality used to be less than 10 years of age. And if you look at the TFR, it used to be as high as 7. And since independence, India has really made those kind of strides. And, I think as an Indian, at least we all can really feel proud of that. And if you look at the mortality, then it mostly used to be, dedicated to the communicable diseases. I think that was the kind of story we started with. And when I said 50% deaths used to be less than 10 years of age group, meaning thereby the adolescent population was really on the lower side. And that was the reason, because We did not have those kind of child health programs and schemes where we could save those children. That's why the adolescent population was low. But if you look at today, India is 75. And as I said, I as a proud Indian, I can always say, though we are, look at the birth cohort, it's about 26 million. It's as high as the population of Australia. We have surpassed China in terms of population. We are 144 crores at this point of time. If you look at the adolescent population, it is highest in the world. So even when China was at number 1 in terms of population, our adolescent population was more than China. I'm talking in 2014. If India was 253 million, China used to be about 200 million or so. So I think adolescent population has always been there. So therefore, I think there was no reason that we don't really focus on the adolescents. If you look at other parameters, I cited around independence. Our under 5 mortality has come down to 32 per 1,000 live births. I think one can always feel proud of it, but still it is on the higher side. If you look at the absolute numbers, then we are losing close to less than 1 million of under 5 children. Again, it is quite high, but in terms of data, averages, it's much lower than what we started. Maternal mortality cut down has been quite tremendous, starting from 1947, currently we are at 97 per 100,000 live births, But still 97 is also very high, I would say. Meaning that by absolute numbers, we are losing close to 25,000 mothers each year because of complications due to pregnancy and unsafe abortions, where, adolescent population contributes a lot. And I always say that, why should a mother die when she gives us a notice of 9 months? It means, there's something surely very wrong with the system, because when, she gets pregnant, the system knows that, yes, she's pregnant, and for next 9 months, if you are not able to look after her, and if you are not able to identify that is a high risk and she can really land to those kind of problems and she can die, I think that's a seriously, So as I said that our averages are quite high, quite better in sense 97 per 100,000 live births, but absolute numbers, they are very astounding. 25,000 mothers we still lose, as on date. TFR has really come down, we are at the replacement level of fertility, it's 2.1. We are a leader in the vaccination program. Undoubtedly, I think we have done pretty well. And COVID management and the vaccination has already showed, we are undoubtedly the leaders in vaccination program. We are, 5th largest economy in the country. And as I said, but if you look at the adolescent population, I think that is where I thought that let me just give you this kind of background. Now, I was talking to Ritaji, when we were taking, tea, that adolescent population is, sorry, you can stop me in case you get bored, and because there's a lot of data and all, and I thought let me just, give a bit of background to you all. So adolescent population is quite peculiar in many ways, and why I say so. This is the second decade of life, and when we say that they are no longer children, and yet they are not adults. Their needs are changing. Their needs are different. So why I say adolescents are different, I think that is one reason. This is the period for their rapid physical, physiological, emotional growth and development. So I think that is an entirely different kind of situation or an age, that they are going through whatnot. Professor Bhatt talked about, their access to internet and to the cyberspace. Obviously, their mind is searching all the time for something different. So that's why I said their needs are different. This is the period when, they develop their new capacities, their capabilities. This is the time when we need to really invest in them. And that's also one of the reasons that they are entirely different. This is all the period because of their changing social, their relationship and roles and responsibilities. Because this is the time when we are transitioning, from childhood to adulthood. So this is the period, that's why it makes them absolutely vulnerable. And unless you really, give a targeted sort of, I would say the inputs, unless we keep them together and say, yes, hey, here we need to go. If you leave them open, I'm sure we all know that what exactly can really happen. Friends, India moved into the demographic dividend phase in July 2018. And when I say, I mean, you are all, bright scholars and academicians, you know that when we talk about demographic dividend and why it is important, because we are talking about adolescents today, I thought let me bring all these perspectives before, I come to a few pointers on the policies of mental health. India entered in demographic dividend phase in July 2018, and this opportunity is available with us till 2055. And this is the period when India can really, make those kind of strides. India can really achieve, we can increase our growth like anything. You talk about Japan, Japan entered way back in 1964. And look where exactly Japan is today, and their growth was more than double digit, I would say. You talk about other countries, you talk about Singapore, you talk about, South Korea, you talk about Thailand. I'm just talking about these countries. Look at China. China entered in 1994. And the kind of growth they really showed was because of demographic dividend. But there's a catch in this. So unless you invest in their education, in their health, in their mental health, and their skill sets, it can turn to be a demographic disaster. So friends, I think India is currently going through a phase which can really take India, to the highest. And I'm sure India as a country with the current leadership and with the dedicated initiatives and programs, India will surely be the leader. We are talking about that we need to become the third largest economy in the world, and I'm sure we'll be there. But unless we invest in adolescents, and this is the time, this is the time. We entered in this demographic dividend phase, I said, in 2018, so already I think it's close to 4 or 5 years. But do we have those kind of, programs and schemes or kind of orientation for the youth? I think that is also a bit of question mark. When you talk about the health issues, adolescent population is supposed to be healthy. We always say adolescents mean healthy. We are not bothered about anything. We are the healthiest, and undoubtedly they are, but still, there are certain issues and problems. I need not to really dilate on these issues and all, but I distinctly recall that in 2006, the Government of India came up with a adolescent health strategy, and it only talked about sexual and reproductive health and nothing else. And we used to think that, it's not only the sexual and reproductive health. Yes, we can say that, okay, early pregnancies can be there, early marriages, early pregnancies, frequent pregnancies, then ultimately, it will impact all these issues, then unsafe abortions. But I think there's so much beyond the sexual and reproductive health. And that was the time when we came up with a new strategy called as new adolescent health strategy called as RKS, Rashtriya Kishore Swasthya Karyakram. So I'll dilate and come to that particular point a bit later. So what we said that, okay, it's beyond sexual and reproductive health. So what about non-communicable diseases? What about malnutrition? So they're a healthy population, but if you look at, anemia in India, especially in adolescent girls, is as high as 56%. So can we really call, Indian adolescents as healthy ones? They malnutrition, underweight. Look at, the young adults, adolescents and youth. So, there are certain factors. Look at the accidents and violence. It's really a cause of concern for India, and especially, when we are losing so many lives, Look at the substance, abuse. So this is the period, non-communicable diseases and mental health. Close to 20% of adolescents, they have something or other, the mental health problems. So 20% out of, let us say, more than 250 million population of adolescents, 20% it really makes it as a large cohort, to tackle and to handle, and especially post-COVID. So post-COVID, the situation has really worsened because, as Professor, Bhatt mentioned, during COVID times, they had no option but to get glued to the cyberspace and to just have an access to internet and all. So I think these are the issues. So it was not, their choice, I would say, but they had no option, sitting inside the room, not getting out for months together. What you are going to do, ultimately you need to have something. And it's not only adolescents, I would say even adults and elderly people, they had no choice but to get glued to the adolescent. Now, when we talk about adolescence, I always say adolescence is a window of opportunity. And why I say so, because if you really invest in adolescents, so you are investing in the current situation, current adolescents, you are investing in the future generations, okay, because of intergeneration kind of thing, and you're also investing in the life stage, kind of issues and problems when we invest in adolescents. There are multiple, why we need to invest more is, it has got multiple rationales. We talk about demographic rationale is one, because look at the population, close to, I think 1.2 billion is the total population of adolescents in the world, so close to 16 to 20% adolescent. In LMICs and middle income countries, the adolescent population is as high as 20% to 25%. Obviously, I think the population is increasing in these countries. So demographic rationale is absolutely important. There is a public health rationale I mentioned about the issues and problems. We lose close to 1.4 million adolescents, each year across the world, which is not a small number when we say that they're healthy populations. Another, the economic rationale I mentioned about, demographic dividend. So if India has to grow or the world has to grow during this particular phase, adolescents have to be healthy. Adolescents have to have quality education. They need to have skill sets, to take the country forward. Professor Bhatt mentioned about the rights of the children. That is also one of the rationales, because why adolescents? It's important that we need to invest. They have their own rights, from 10 to 19 phase group, and the child's rights, they are available. So that is also one of the rationales. Friends, if you have to achieve SDG, I'm talking about SDGs by 2030, the post-2015 agenda or 2030 development agenda, then I would say the 20% of population, you can't really leave them. So there is no reason that we leave this particular population. So if you have to achieve, if you have to ensure that SDGs are achieved by 2030, adolescents have to be in the center stage. For all the SDG goals I'm talking about from 1 to 70s, adolescents have to be, the partners and participants in the whole process. Friends, coming to, some of the policy initiatives which India took, I would say 2014 was the year, I would say the golden year for mental health. In October 2014, India launched the new national mental health policy. And I fondly remember my guru, Mr. Desi Raju, the man behind this policy. We lost him last year. But I think one person who really worked hard on this, because mental health is not everybody's cup of tea, unfortunately. So anyway, any problems, you look at, whether clinicians or anybody or even family members, it's something that people would try to avoid. And Mr. Siddesh Raju, as additional secretary, as special secretary, he was just sitting almost every day on this particular policy. And friends, it's one person who needs to be lauded for this is him, that he came up with this wonderful national mental health policy, and that was launched. So he was not there, but it was launched in October 2014. But I think we dedicate this particular policy to him. And the vision, obviously, behind this policy was that we need to promote mental health, undoubtedly. We need to prevent those mental, illnesses. So prevention is another aspect. We need to enable the recovery of, people with mental illnesses. How best we can, sort of prevent, and promote destigmatization, because stigma is so high and hugely attached with mental health in any age group, whether it is children or it is adolescents or all elderly people. So, and then obviously how to make them part of the society where they can be the potential, I would say, contributors to the economy of the country. And so they have to be part and parcel of the socio-economic cultural milieu, of the society. And it's not, India did not stop there, but in 2017, they passed this called as National Mental Health Care Act, where they ensured, it ingrains the rights of the people with mental health. Absolutely fantastic. But friends, I'll come a bit later on this. And what it talks, it talks about the rights of the people with mental health. It talks about, access to their mental health care, undoubtedly, I think. So they have to have a universal access to the mental health care. Their rights to living in the community is another right. So we have to ensure it's part of the India's law. It has been enacted. Protection from the cruel treatment and kind of mismanagement. The right to the confidentiality, again very important, because it's not that we are going to open up the records to everyone. Access to his own medical records, and restriction on the release of the information. So I think, these were I would say the rights. So I really don't want to get into this whole act. But firstly, a national policy on mental health in 2014, followed by an act. I think it speaks volumes about the commitment of the country towards the people, whether it is children or adolescents or elderly people, in mental health. But I always say that, the intent, there's a gap between intent and implementation. The policies and programs, they are wonderful, nice documents. But what we suffer, I've seen is that, I was in the Ministry of Health and we came up with tremendous policies and programs, almost all the high impact interventions under these 5-6 pillars. But implementation is a major issue. So can we say that yes, India has been able to implement the policy, the mental health policy? Whether India is able to, let us say, implement those kind of the kind of rights which a mental health, a person with mental illness is going to have. I don't think even many people would know about this. So friends, this gap between intent and implementation is something which I would say is that needs to be bridged without any further delay. Now the second important program which I always say is, we came up with, and this was 7th of January, I distinctly recall, this 7th of January 2014, we launched this new adolescent health strategy and the program. And what we did was that we were thinking that, since 2006 we had this, in the name of adolescent health, the health is only the sexual and reproductive health, kind of interventions in place. But you said we need to expand the thematic areas of adolescent health. And this is how, then we added 5 more thematic areas. We are talking about, non-communicable diseases, because when you talk about non-communicable diseases, I said this is a window of opportunity. If you are able to ensure that the high-risk factors, those 4 high-risk factors, friends, we talk for non-communicable diseases, we talk about tobacco, we talk about alcohol, we talk about unhealthy food and physical inactivity. These 4 high-risk factors, they basically lead to non-communicable diseases. So India basically, I would say, surpassed the communicable diseases, the non-communicable diseases surpassed the communicable diseases in 1990. And this is how they took over. So, and these are the 4 high-risk factors, they were behind this. And why I say so? Because if you talk about alcohol, we talk about tobacco, we talk about physical inactivity, this is the adolescents, these are the students who are not really getting, into, they are basically having access to tobacco, alcohol. So all these bad habits, which contribute ultimately in later years of life to non-communicable diseases, this is the age, this is the window. So friends, if I'm diabetic today, so it's a lifelong management for me, So the best approach to prevent non-communicable diseases is this window of opportunity that is adolescence. So that's why, and whether we were talking about mental health or any particular region, I think this is going to be important. So we added these 5 more thematic areas. I said the first one, beyond sexual and reproductive health, it was malnutrition. We added to this that we need to focus on the nutritional status. Non-communicable diseases, injuries and violence was another one. Substance abuse and mental health. So mental health was a predominant chapter in this particular strategy. We said we need to, because if you're talking that 20% of adolescents in the country or globally, they have some mental issues, so we can't really leave it. And we adopted a 4-pronged strategy to this. And the strategy was about promotion. That is the first prong, and it talks about, how can we, basically the promotion, how can we promote the protective factors such as self-esteem is very important, in adolescents. Healthy relations, another, how best we can. So this was basically, the promotion part. Preventive part, obviously, we need to screen, adolescent for the anxiety, for anti-mental illnesses, because screening is also missing in the whole system. And I'll come to that a bit later. Similarly, how best we can add to the skill sets, so that, we can prevent these kind of mental health issues. Third was very important, prong was your management. So what about the management of, let us say, adolescents who are having, some sort of mental issues, whether it is illness or otherwise. They're talking about anxiety or depression, anything we're talking. Do we have those kind of systems? I think that was very important. And the fourth, it's not, I would say, it's not the last one, but very important is about awareness. Because there's so many things, I mean, if we have to work on prevention of these issues, friends, as I said, we should not allow these issues to land into mental illnesses. How best we can prevent and keep, our children and adolescents healthy in terms of mental health. So the prevention is going to play an important role, and there the awareness in the community and societies also becomes of paramount importance. We also came up, so this new strategy, adolescent health strategy, was called as, RKSK, Rashtriya Kishor Swasthya Karyakram. But I'm very, happy, and I'm sharing with you that mental health was an important component of this particular strategy. Friends, so I said, 2014. In 2013 also we came up with another, scheme in the Ministry of Health called as RBSK, Rashtriya Bal Swasthya Karyakram, where it was a, screening program from children between 0 to 18 years of age group. So that also included adolescents. We identified 32 sort of interventions, issues and problems, including mental health issues. So school health program was subsumed into this particular program. And we also basically, used to have teams going to, different, either through the schools. So screening used to happen through two things. One was school, another was the children or adolescent out of school. So from 0 to 18 years. So 32, and we also established something called as district early intervention centers. So children having some mental issues, any of these kind of problems or developmental, sort of disorders, so we included. So when we said that RBSK, so there were four sort of, you can say, pillars which we considered. The first pillar was screening has to be done for the deficiencies. The second D was screening for the diseases. The third screening was around defects at birth. And fourth, which I pushed actually, was, developmental delays and disorders. Again, these are a bit of, developmental issues or mental issues was very important. So friends, what I have tried to give you a kind of landscape, how we have evolved over the period. But I would like to, conclude, this particular, my speech with 4 or 5, I would say, actionable points, which are very important, because I don't want to leave something that you go back with, this kind of information. But I think I said the more important is action, And you are doing a tremendous work, because when I heard from Rita ji, from a couple of colleagues, I think I said, people who really work in this particular sector or area, they are, I would say, different people. I said, it's not everybody's cup of tea. How many people who want to work with people with mental disabilities or mental illnesses and all? How many people? They'll tend to avoid. So friends, my first recommendation would be that we need to invest in youth, we need to invest in adolescent, and especially adolescent when talking in adolescent health and in particular mental health, because we can talk about adolescent health, but mental health of adolescent is still a missing piece in the whole pie. So I think we need to bring in a sharper focus on mental health of the adolescent and children and well-being, and then we have to, so we have no option but to invest. India needs to invest, and especially during this demographic dividend phase. So unless we invest, how can you expect an adolescent or a child to contribute to the economy of the country with mental, illnesses? So I think that is my first recommendation. The second would be that we need to raise awareness about mental illness to reduce stigma. And that is, some way, this month of May, I would say every month should become a month of May as far as mental health is concerned. Why should we have a day or a month dedicated? But at least because we don't do things, so that's why we have dedicated days or months, but it's absolutely paramount importance. We talk about stigma, friends. I was just going through one of the important, articles, because I said, let me just see. So when we talk about stigma, the greatest stigmatization, is related with the peers. About 62%. If some child is having, mental issues and problems, so first and the most, I would say, stigmatization comes from the peers. And what happens that the friendship is gone, and it's as high as 62%. The second is from the family members. So very unfortunately, who's going to look after the child or adolescent with mental health issues and problems if the family is not? So that is also as high as 46%. And what happens? There's this element of distrust. I think that happens. They tend to avoid, bacha problem hai, just avoid, So the avoidance behavior, that is so very unfortunate. And third is from the school staff. If some child is going to, and that is also as high as 35%. But it is not that isolated, that 62% peers and then 46% parents or the family members and then 32% or 35% from the school staff. But there's also a combination, because so this child or this youth or this adolescent with mental health is having multiple, a mix of stigmas coming from the family members, from the peers, so I think it's of absolutely important that we start working around these awareness, especially to mitigate the stigma part. The third is, yes, we need to educate the communities. We need to strive and to educate the communities about mental health issues, and how, because an unhealthy, let us say, because of mental issues and all, they can't really contribute to society, to economy. So I think because I don't find a solution, barring a few percentage of children or young with that real illness. I find the solution within the community for these adolescents, having some mental health issues and all. I think so even if you find the best possible psychiatrist and all to deal this particular child, still the community has to look after the needs. So unless community is oriented, the community is sensitized, unless the community is, or the family members are sensitized, it won't lead, to the full recovery of the child. The fourth, I say that, simple solutions, especially for promotion of, these kind of solutions, I would say, simple, deep breathing exercises, yoga exercises, meditation. We talk about, proper sleep, children nowadays, where's the sleep, They are sleeping at 4 o'clock in the morning, waking up at, 12 o'clock in the day. So sleep becomes very important. Unless you take a sleep for close to, 7 to 8 hours, I think it's going to be absolutely unhealthy. But the right kind of sleep is also important. Relaxing music, again, very important. So these are simple solutions which can really keep the younger population, healthy. Professor Bhatt mentioned about the cyber, access. So this detoxification, digital detoxification becomes important. So we need to have some time that, children should not have access or the youth should not have access. And I think this, as a family, we should try to, one should try to, sort of propagate its, his or her own hobbies. If somebody is good at painting, let us start painting. Somebody is good at singing, let us start, singing. So these are important. And then obviously it's very important that we avoid these kind of unhealthy habits. As I mentioned, we're talking about tobacco intake, we're talking about alcohol or, physical activity, inactivity. So I think exercise becomes very important. So quite a youth, I'm finding they are becoming, quite they want to get into that kind of fitness mode. So that's a very healthy sign, I would say. And then unhealthy diet, I've seen, why should somebody go out and go for a junk food? So I think these are important things. I'm not against junk food, but, to keep our populations healthy, So this youth or the adolescent won't really understand the problems which can really crop up later when they become adults. So this is the time, I said, the window of opportunity. Now the fifth point is, what about the human resource? Do we have right set of human resources available to tackle and handle with the mental health issues and illnesses? We don't. I think if India is suffering, because generally you'll find that 10% of people or the population is having mental health issues. So do we have those kind of number of psychiatrists, those clinical psychologists and psychologists? I think that's, so I always say that insufficient human resource will lead to inefficiencies in the system. So how can you handle, people or youngsters, who are having some mental issues and without a proper human resource? So I think India needs to really start working, pushing that. We need to, maybe we have some specialized courses and programs, developed so that even physicians, not only MBBS doctors, but maybe homeopath, maybe anybody, or maybe even a plain graduate, can get into, because there are multiple levels of, dealing with these kind of youth, starting from counseling to as a peer, it becomes important. So can we have some programs that can start, from the colleges itself, in the universities also, because ultimately somebody needs to really focus on this. My recommendation would be on this is that we need to implement all these policies and programs. So I said, friends, I've been part of the government and I'm still part of the government. We are good at coming up with the good policies and programs, but ultimately whether they are being implemented, so I think a solid monitoring of what we are proposing becomes important. So in 2014, I'm yet to see whether when the National Mental Health Policy was sort of, inaugurated, and especially RKSK, whether we have been able to really implement this in true Latin spirit. I think that becomes again the major question mark. So I think we need to, as I said, we are good at making policies. So India has got, I would say, the best of the policies and programs across the world. But what we lack ultimately is the implementation. Friends, risk behavior screening becomes very important, especially for people with mental illnesses. I was going through an article, and especially this was a study which was conducted in 11, they got the candidates from 11 countries in Europe. You must have gone through this. And to my surprise, I was amazed when they conducted this, study on more than 3,000 candidates. And I was surprised. They said they identified 61% of these young people, at risk of any mental issue. And out of this 12%, or rather 12.5%, they were found to be requiring some mental health, management of the treatment. So such a huge, I'm talking about Europe, look at India, look at the numbers. So if 60% are at risk, and another 12.5% they required a solid or a real management of treatment, so you can easily make out that, where exactly, we stand. And finally, friends, I think the kind of leadership is required in this way. Ultimately, it's the people who make difference, nothing else. So that leadership, the political leadership, the advocacy issues and programs, in my view, it should become a movement. Nothing short of a movement can really save this, country or the world, from this disaster. I think we have to be absolutely there. Pritaji, I must compliment you that you and your team, which is a tremendous team, has doing a great job. But as I said, we need to have more such organizations. Government has to be right in the, we are talking about everything, RCS, I recall, the kind of work which it did. It's not that that's not important. Vaccination is very important. But what about this? Who is going to do this? So friends, I'll pause here for the time being, and I'll be very happy to take any questions and queries in case you have. But Ritaji, thank you so much again for inviting me to this important conference. And I'm really, privileged to be here. Thank you so much.
Thank you, Dr. Kumar. I need not to reiterate anything. It was so simple and so clear. But I think I would like to add one more point with the government efforts after 2014 is the new education policy of 2020. The government of India has introduced a new education policy, and in this new education policy, an old concept of school complex has been initiated. That school complex concept was given by Kothari Commission in 1964, and the school complex is a combination of different schools at one place. So the common facilities will be delivered and it will work under a trained social worker. The whole idea of this school complex is to prevent the bullying, to reduce the dropout rates, to address the children issues at one place. So the government has proposed that this school complex will be headed by a trained social worker who will be trained into the beyond the mental health activities also. You know, organizing games, conducting group work programs, likewise. So, I mean, I will, those who have not read it, I will request you, it is a good concept given into the draft of the National Education Policy and the main education policy. And we are looking forward that government will introduce this concept, because many problems of children are that there is no one to listen them. So this provide a direct interaction to a trained person who can solve the problem. What he says at different levels, we need the people and we need the human resource. So I just want to add that. And similarly, many schemes have been initiated time on for the college students. Like National Social Services Scheme was one of them, NSS, which he has touched upon. And there have been the clubs for the good health, career and counseling. So I think we need to take up these issues as a part of the recommendation of this conference, that how the gap between intent and implement is to be bridged up. So thank you, Dr. Kumar, for wonderful landscape you have given for the whole ministry, what it is doing. Right. So we have to go for the report release.
Yes, we have. Is there any questions that
Yeah.
you would like to ask? Yes.
Very good morning, sir. Thanks for enlightening talk. I am Jayduth Bhatt. I am psychiatric social work PhD scholar in NIMHANS, Department of Psychiatric Social Work. So my question would be, sir, because I am at the junior consultant at the Psychiatric Rehabilitation Services of NIMHANS. So some of the implementation of Rights of Person with Disabilities Act I have seen, where the State Advisory Board on Disability is constituted, where our department actively goes and attends meeting and gives to the government of Karnataka those kind of inputs, how a person with mental illness or those kind of disability who are in remission can be accommodated in government job, and what kind of reasonable accommodation those the employer has to give. So that kind of capacity building we are into. Also there are like mental health review board, only 2 mental health review board currently the state of Karnataka is, and after much of the deliberation there are for all 31 districts they want to have each district mental health review board which will be chaired by district judge rank, and there should be some person with mental illness, caregiver, all those representative as per the mandated by the law. So in that development, as being in academic field for some time, I feel that we are doing substantially, but I need your suggestion also. So there are certain individual will come to us. We know the policy, but there is a gap is there. Like I am academician, other is the district authority. So there is a gap is there now. Some national carrier service or those kind of bodies are started coming to the institute. I like for enrollment in Niramaya health insurance, those things. But there are certain bodies has to come more, like those kind of schemes whether the awareness among the social worker who are in pursuing MPhil in those or certificate course in those educational institute know about our own policy, whether we are able to have like a curriculum which is questions them regarding that, and also like intensive kind of internship with those kind of ministries where they will get hand-on exposure, because if they have PhD related to the topic of child and adolescent mental health, if avenues are not created for those kind of, so what the government is doing in this, and what recommendation you will give to the government also, because I am happy that I have observed that AIMS Rishikesh has came, AIMS Bilaspur has came, but there is a need to strengthen the psychiatry department within that. Then it will come child and adolescent psychiatry within that subspecialty. So we have to go a long way, I feel, and there is a tremendous work is required. What will be your, like, to us as a academic body, what you will suggest, which way we can also go to improve ourselves? Thank you.
Thank you. It's a wonderful question, and I don't really, I can't really agree more to what you have said. As I said, there's a huge gap between, the intent and the policy and implementation, because the policies are drafted. I'm not saying that we sit on these kind of issues and draft more. It does, have that kind of element of research, and the experts are sitting and doing it. But when it comes to implementation, I've seen one thing, that whatsoever we create, somehow maybe because of lack of time or maybe lack of interest or whatsoever you can call, things don't really happen now, because you look at the district authority, you look at the state authority, they have no time. Most of the time that goes into. So in my view, if somebody has, I think they should find, those kind of, people who are really keen. They should become, our investors. They should be nominated by the government to take it forward. Because if government, let us say, Secretary of Social Welfare or let us say Health is available, he doesn't have time. You won't have time for other programs before the governmental health and all. So what to do? Maybe, some professor at one of the institutes and all, why he or she can't be the investor and can lead the program, whosoever is interested. So such kind of, so this could be my one, recommendation. Secondly, look at the, who could all other be the investors? I said, the students directly, the PhD candidates.
Peer.
Candidates from, from social welfare departments, masters, PhD. I think those who are really engrossed in these kind of schemes and programs, so I said they should be part of this implementation process. Otherwise, things won't really happen. Now, if you look at these doctors also in secretary department, you go to any department, anywhere in the hospital, where's the time? They are all. So where's the time for, let us say, for the preventive and the promotive activities in mental health, especially for the adolescents? So I think the peer group, peer groups can also be an important role. In the society, let us say, what about these school teachers, the college teachers? They have to be part of the whole process, because who is handling this, second decade population, is basically these teachers and the peer. So I think if we are able to engage the teachers and the peers, then I think the best one, when we're looking at this program holistically, so we brought in the professors and teachers and the peers in the center stage, because more than the treatment, as I said, it's basically, we should not allow, we need to work on the preventive and the promotive side. So we have to get out of this, the state executive, the policy maker, the secretary, the district magistrate, the secretary. No, they will play their own role, but there are so many actors and players.
Correct.
Who should become part of the implementation process? So anything you talk, they can, you can generate data. You can generate data and you can take it up. So maybe the district magistrate needs to be sensitized, maybe once in a month, and taken to. But as I said, it's all about human resources, friends, and also the human resource which is dedicated. It's not like everybody would not like to be in this particular field. You tell me, people would, in the medicine would like to prefer to go to what? To go to general medicine, to general surgery, to different kind of specializations. But you tell me as a pediatrician also, how many pediatricians would like to become the developmental pediatricians, or the, let us say, who will be dealing with the children with special needs? Not many. So I think we need to basically enlarge the cadre of human resource, and that is a huge challenge before the government. How to motivate them to become the caregivers of healthcare providers. So that's why I said, even if we need to expand, so let us not restrict ourselves to these only clinicians or the allopaths. No. Let some homeopath, let some Ayurveda, let some person who is specialized in social welfare kind and all. So we need to expand the basket of these healthcare, mental health care, providers, and this is how we can deal. So the expansion of basket is to me is the solution. It can't be handled by the policy makers or by the district magistrates or by say psychiatrists who are working in the clinics and in institutes like AIIMS and all. They can provide input from time to time, but the solution lies somewhere else.
Yeah, right.
Yeah. Good morning, sir. Myself, I am Dr. Praveen. I am academician, practitioner, as well as working in this field of mental health since last more than 20 years. First of all, thanks for your elaborate presentations. You have focused about the National Policy 2014 and as well as the Mental Health Care Act 2017. I know the problems are enormous related to the children and adolescents. There are a lot of governing bodies also, including the NCPCR and DCPCR, as well as the NGOs like Butterflies, the Childline, as well as Salam Balak Trust and Uday, and so many other NGOs are also working in the field, particularly in Delhi and adjacent areas. My questions to you, sir, these policies are very much in the place, but the problem is, as you have listed, that implementation is really not taking place. When we talk about the NCPCR and DCPCR as well as the state level, but still now, day to day, we get a lot of issues highlighted in the newspaper that this has been happening with the childs, particularly the adolescents, particularly the less than 10 years or less than 5 years. The crime rate is also very high. So we need to think something out of the box and have those kind of counsel at the district level as well as the local level child protection committees or district level child protection committees. And you have also beautifully mentioned in the recommendations that the awareness is also one of the very important areas. And the stigma related to the mental health, in general, I am talking about the rights of the child, educational rights, their rights to live with the dignity, right to live with the economic rights and all other things. But the government also needs to reach to the grassroots level and then implement those policies. Sir, it was very nice to hear that in the national education policy also you have talked about the school complex. Those kind of things can be there right from the panchayat levels to the rural areas to the district level, if that can be possible. So definitely these issues or this menace of the child abuse can be controlled and very effectively can be dealt with that. So I think that this district level, local level councils also is a need of ours. So that can we also think about it. And thank you, sir.
I think it's a good idea. And as a practitioner and academician, you have the capacity to write to the policymakers and implementers, because intent and implementation, what he said, is very important. So, and don't go on newspaper reports, because all newspapers reports only the bad news, not the good news. Good work is not being reported, especially in social sector. You will find lot many, if there is a one mistake into the ICDS program, it will be highlighted at national level. But if there are 10 good work is being done, it will not be highlighted. And you know that how we have shifted from ICDS to ICPS. And the one big system which we have created in the country, it is at par with many other countries and far good in many other countries. I will recommend you to read a global handbook on child protection system. It has a child protection system of the 50 countries. Unfortunately, I read that and I find that India has much better, much advanced child protection system. Of course, we have certain, bottlenecks. Anyway, so your point is well taken, and there is no denial that there should be implementation faster at the local level.
Just one point to add to yes. I'm not going to those kind of bigger details, but when we are, let us say, constructing policy, in my view, there should be a framework for implementation. That should be a part of the policy. But essentially what happened, so I was working, pro bono, pro bono means, obviously I'm in a different capacity, but I work in the head policy of Uttarakhand, 22. And I said, policies, they keep on eating dust, in these, policies, but unless we have framework for implementation, how part is missing? So that should become part of the policies. You may get, but this is part of policies. This may not be the policy, but the framework for implementation should be there. And then we can have these kind of capabilities and bring into this. Thank you.
So thank you very much. Thank you, Dr. Kumar, for very enlightening points. You have added the value to this conference, and we are really grateful. And thank you, participants, for being a good participant, listening it, and thank you, organizers, for giving us this opportunity. So this lecture session closes here. Now I think there is a new announcement for the release of the study. Please.
I would like to thank Dr. Sanjay Bhatt sir and Dr. Rakesh Kumar sir for giving such an enriching context and direction to our today's proceedings. So thank you very much. Now I would like to share that it's time for the release of the synthesis report on boys affected by sexual violence. Therefore, I would request Srimati Rita Panikar ma'am and Mr. Rajiv Roy sir, who is the Senior Program Advisor for Violence Against Children, Family for Every Child, that is an alliance of local civil society organization from Latin America, Africa, Asia, America, and Pacific. So I would request you both, I would request her to please proceed to the dais and ma'am to speak a few words.
You will give it. I'll just to briefly say a few words about the synthesis report. The synthesis report came about in 2017-2018, and it was finally completed in 2019, wherein there were 4 of us from Asian region, and that is from my colleagues from Philippines, Zeni Rosales from CPT-CSA. We had Mr. Shamaroon from the First Step, Cambodia. Mr. Krishna Thapa, he was from the Voice of Children from Nepal, and Butterflies. We did this study, which is an empirical study on boys experiencing sexual violence. Because when we speak about sexual abuse or sexual violence, we always look through the gendered lens and think it's most often happens only with girls, but also boys are experiencing sexual abuse. They're most often seen as perpetrators of a crime, but not the victims and survivors of sexual abuse. So we did this empirical study. It was not a survey, it was actually an empirical study. And as a fallout of this empirical study, or I would say a follow-on of that, was that we know that in Philippines they have changed their laws on sexual abuse, and it is today a gender-neutral law, just as we have in India POCSO law. They too, which is gender-neutral, they too have it. In Cambodia and Nepal, the policies, there have been amendments to the policies, especially when it comes to be working in school sectors and with the judiciary and the law enforcement machinery. And I would like to call all 3 of them up onto the stage too, while we release the report.
Little old, now retired.
And Rajiv Roy is actually the one who is working on this with us in Family for Every Child. You can keep. You can. Yeah. I must say that, the 4 studies, there were so many things that was common. And one of the things that was very common was that about the boys, that all in 4 countries, the whole idea or notion of boys is that they should be brave, strong, and courageous. Thank you so much. Thank you.
Thank you, everyone. Now I would like to invite Mr. Chandan, Head of Children's Cooperatives Program, Butterflies, to propose the formal vote of thanks.
Thank you, Dhriti. I think half of the work is actually done by Sanjay Bhatt sir. He already thanked, but I have to do this. On behalf of Butterflies and the organizing committee and all the delegates, it was privilege and honor to listen to you, sir. And you are a doctor and has been an administrator. You blended all those and gave a very comprehensive information to us. So that was really good. And I'll say you actually put the adolescents at the forefront. And most of us read in psychology that adolescence is a period of a storm and a stress, but you termed it as a window of opportunity. And that's a shift from negative to positive. I take that as a great takeaway. Thank you so much, sir. Thank you so much, sir. And obviously, you talked about the legislative framework, and I really like, and I think most of us benefited from the action points. Those are really practical action points, and I think that's where your administrative experience has actually, has been handy to us. Thank you so much again, sir. Now, Professor Sanjay Bhatt, sir, really thank you for chairing the session, and you also stressed that children as well as adolescents needs to be safeguarded, and I think few recommendations always come from you that you have to read this. So thank you again, and it was indeed, great always listening to you. Thank you so much, sir. Thank you so much.
So now it's a time for a tea break. I would request you all to proceed towards the hallway, and we'll resume here sharply at 11:40. So please be back by 11:40. It's a request. Where is Arch? I hope everyone is back. Welcome back, everyone. I hope you have enjoyed your tea. Now we will proceed with our first panel discussion of the day. The panel discussion is on mental health of boys affected by sexual violence and the national mechanisms that are there to prevent and promote mental health well-being for boy survivors. I would request the chair and keynote speaker of the session, Dr. Achal Bhagat sir, psychiatrist and chairperson of Sarthak, and the panel speakers, Ms. Zenaida Rosales ma'am, Executive Director of Center for Prevention and Treatment of Child Sexual Abuse, Philippines, Mr. Y.M. Shamaroon, Executive Director, First Step, Cambodia, Mr. Krishna Kumar Thapa sir, Director of Children of Voices, Nepal, Mr. Mohammad Sharif and Ms. Priyanka Lakra, Program Officers of Child Protection and Mental Health Program Team of Butterflies, to grace their seats on the dais. Thank you. Now I would request Mr. Varun to greet Dr. Achal Bhagat sir. Thank you, sir, for joining us today. Now I would request Mr. Manoj to greet Ms. Zenaida Rosales ma'am. Thank you. Now I would request Mr. Alam to greet Mr. Y.M. Shamaroon sir. Thank you. Now I would request Mr. Hassan to greet Mr. Krishna Kumar Thapa sir. Now I would request again Mr. Alam to greet Mohammad Sharif. And I would request Ms. Richa to greet Ms. Priyanka Lakra. Thank you all for your presence today. The chair of the session is Dr. Achal Bhagat sir. He is a specialist in child and adolescent mental health. He has completed his MBBS, MD, MRC Psych and is a senior consultant, psychiatrist and psychotherapist at Apollo Hospitals and chairperson of Sarthak. An organization works on mental health issues of children and adolescents. A warm welcome to you, sir. Now, I would like to hand it over to you to chair the session.
Thank you. Good afternoon, everybody. No, it's not afternoon yet. Well, nearly afternoon. Thank you for being here, and it's interesting to see international conference on child and adolescent mental health without too many psychiatrists here, which is good. Thank you for organizing an interdisciplinary conference, Rita and Butterflies. The way it's going to be structured is that we are going to hear panelists from Philippines, Cambodia, Nepal and India first, and that will make my job simpler, and then I will collate what they have said and paraphrase it without using ChatGPT. So I think I would invite Zinaida, have I said that
Yes,
right? From Philippines, who's the co-founder and executive director of Center for Prevention and Treatment for Child Sexual Abuse, and works on the issues of individual, group, and family counseling, and is an activist who has been on many committees, including being an active member of Philippine Juvenile Justice Welfare Council, and is the current vice chair of Family for Every Child Board of Trustees, and co-chairperson for Sexual Violence Prevention Working Group of Family for Every Child. And she's the member initiator for the International Blue Umbrella Day campaign. We were just talking before we started this process, and she was. We have many shared experiences, similar experiences, and it'll be useful to hear from the Philippines perspective as to how boys and men are supported through their journey of survival. Thank you.
Yes, sir.
So I think each speaker has about 15 to 20 minutes. If we want to get to lunch on time, we'll keep time, or I'll speak less.
It's not working. Okay. Good afternoon, everyone. I stand before you now amazed with the wealth of information, expertise, wisdom, passion in this room. And thank you, Rita, for organizing and providing us the platform and to invite us to join in the dialogue and conversation about mental health on children and adolescents. Now for my presentation, this is all about how research and advocacy transform people who are victims of sexual abuse when they were young, especially male or men, and how also a community change and even a country to participate and really help in protecting boys from sexual abuse and exploitation.
Right, we need some help on
It's not working. Can somebody? Okay, for some context, the Philippines, our population is 110 million people. And of this, we have 36 million children. And according to our national baseline study on violence against children, this is conducted by the government in 2015, 2 in 3 children experience any form of physical violence. 3 in 5 children in the Philippines experience some form of psychological violence. And 1 in 4 children suffered some form of sexual violence. And 2 in 5 children experience online sexual exploitation. And it's very sad and alarming that the Philippines now is considered to be the center of child pornographic production, the center of production of child pornography materials, and at the same time, online sexual exploitation. And in overall, abuse in schools, communities, and homes, boys reported higher than girls at 81.5% and 78.4% for girls. With the rate of psychological violence, it is 65.2 for boys and 60.4 for girls. And more boys reported experience sexual violence at 24.7% compared to girls, that is only 18.2% in our country. In the beginning, the country or in general was surprised about this incidents, higher incidence of sexual violence against boys. But for us in our office, it was not new to us, because right from the start of our work in 1995, we were already receiving cases of boys sexually exploited either by their neighbors or friends. So in order for us to understand the reason behind the high incidences of sexual violence among boys in the Philippines, CPT, CSA, Butterflies, First Step Cambodia, and Voice of Children Nepal, we work together to conduct a primary research on boys, on caring for boys affected by sexual violence, and this is funded by Family for Every Child and World Childhood Foundation. For the interest of time, I will just go directly to the common findings that we have across four countries. And one of them, that boys have more freedom and fewer restrictions than girls, but they can be less protected as a result. In the Philippines, we really raise our boys and girls differently. We give our boys more freedom because according to one child in the study, their parents, caregivers, or relatives do not worry too much about them when they are outside because they are boys, and boys will be boys. Boys can protect themselves. Unlike for girls, girls can get pregnant and be raped. So for this particular boy, he said that girls in our country, in the Philippines, are really protected than us. This particular perception and notion really make our boys more vulnerable to all forms of sexual violence. And based on our cases, boys are usually abused outside their homes. And usually they are abused in groups because the occasion would be during sports tournaments, jamboree or scouting event, and even religious retreats. And for boys, they were conditioned that those activities were okay for boys as their initial sexual experience. So many boys were not able to report until somebody would caught them doing something, inappropriate, like having a masturbation or having a sexual activity with their friends. The second finding is real men are strong and brave, and physical violence is an expression of being a male. Boys characterize the definition of real men as always characterized being courageous, independent, physicality, meaning they must be strong, they must rescue somebody but not to be rescued, and there was also a pressure to suppress their emotions because emotions are for them are for girls, feelings and emotions are for girls, so therefore feelings and emotions are not for boys. Again, with this notion, when boys will encounter some problems, it would be difficult for them to express their emotions. So their way of coping with their emotions could be into aggression, and aggression for them could be somehow accepted when they perceive it as needed. And most of our boys, resorted to drugs and alcohol as their way of coping their emotions and some struggles because they are not trained to approach someone to tell that they have a problem. Third is being a man means being a family protector and provider. In the Philippines, these are the two major pressures that our boys are also facing. That they have to, as protector, they have to protect girls and women, and as provider, they have to earn a living. Therefore, some of our boys opted to stop schooling so that they can begin helping their families and sending their little girls or little sisters to school. You can find these boys in farmlands, sugar canes, and if they are in the cities, they're doing sidewalk vending. Therefore, most school dropout is also higher among boys in our country. Another thing is a boy learn about masculinity and sexuality primarily from their friends and the media and the internet. And this is true in our country. Boys learn sexuality from the internet and other wrong source or people. And this is being heightened by the COVID-19 pandemic, where boys and everybody of us were locked down. And another reason for that in the Philippines, parents are not really ready to teach and discuss sexuality among their children. And there is a move that we have to teach sexuality in the school system. But the Catholic Church, 80% in the Philippines is Catholic or Christians. They are the one opposing and suggesting that sexuality must be taught in our homes. But look at the parents, they are also struggling to do the same, and even children are ready to learn about sexuality, and it is the parents who are not ready and so scared and even afraid to discuss sexual terms and sexual matters. So our boys are lost along the way, and they become vulnerable to all forms of exploitation offline and online. The dominant perception that boys are abusers but can't be abused, this is again related to the notion that feelings and emotions are for girls, that girly things are not for boys. And when boys are sexually molested or abused by another man, the issue of the confusion of identity and the stigma and fear of being homosexual is so high. In the country, Philippines is just an homophobic society. Homosexuality is not accepted. And being a Christian country, homosexuality is considered to be a sin. So therefore, when you're doing homosexual activities, you are labeled as sinners. And these are the pressures that boys are struggling with in their search for meaning, and especially in looking for definitions and meaning about their identity around sexuality. And the fifth one is about dominant perceptions, and the last one is support for boys affected by sexual violence in the country is very limited. Boys victims of abuse and the actors, boys who are already displaying harmful sexual behaviors, you can find them in the institutions where services are generic or general, meaning all programs and interventions are true to all regardless of your gender and issues, because these are children in the institutions are mixed, boys and girls. And secondly, the staff there in the institutions are mostly women who are trained to help girls and women. So therefore, when during the interview, the staff were also really sharing to us their struggles on working with boys who are already having some sexual problems, because boys are not that ready to share the information with them. So they are also struggling working with boys. And if there are services for boys outside, they are limited. We have clinicians, we have psychiatrists. They are difficult to find. And if we can find them, they are expensive. We cannot afford. It's another trauma for the parents to know how expensive it is for somebody to get, as a clinical assessment and therapy. Now, why do we do research? We are not just doing research for just doing it. We do research because we have a purpose. So for the research, it gives us a country-specific and empirical data to define and design our international and local movement building. So in 2022, Family for Every Child, the global alliance of 45 countries now, launched the Blue Umbrella Day International campaign. And this is really to raise awareness on how we can better care for our boys and protect them from all forms of violence. This is now being observed by 25 countries around the globe, and it is now being recognized by the International Society for the Prevention of Child Sexual Abuse and Neglect, and this is also being supported by ECPAT International and more. So for our country, like in the Philippines, we are also proud to say that we were able to come up or establish our Blue Cap culture movement also on the same year in November 2020. What is significant for this particular movement, it is the people who are victims of sexual abuse when they were young. There are male, they are now grown up men who come up and share their stories to us. And now they are the one leading, and they are even the founders of this movement now. And I think this is the strength of our movement in our local context, because they are now the faces and voices of this particular campaign. And we saw it very effective because they are the one who validated and invalidated some of our claims in our research. And no one can contradict to their messages, because they said, we are not experts, but we have the experience that you are talking about. So please do not talk about us without us. So therefore, we are now giving them the platform to lead the movement in the country, and they are even now ready to join the international movement. And the guy in the picture is the founder and a survivor of childhood sexual abuse. Now, what was the effect of this particular research and campaign? We are also proud to say that constant advocacy, constant campaigning at all levels, from the grassroots down to the Congress and Senate, enabled us to come up with the landmark law. Now, this law is very significant because this is we were able to increase the age of sexual consent from 12 to 16, and this law also equalizes the protection of girls and boys from all forms of abuse and exploitation. Rape can now be applied to boys and men. Before, it was only for women and girls. Now, advocacy is okay, but we have to go beyond it. Because one of the claims of the boy is that we need our fathers to be available to answer and discuss with us our needs and concerns. So the Father-Son Communication Toolkit was launched last Friday. And this Father-Son Communication Toolkit about sexual health and well-being is a training module for carers. This is not for fathers. We are training carers like male social workers, male counselors, to help fathers, do a safe and meaningful and open conversation with their sons. So we are, fathers are supported on how to begin and how to open, and we just piloted this training, and we found that some fathers are really having some difficulties in discussing this concern. But with a lot of support and coaching, fathers were able to navigate the expectation that they have to try out the manual with their sons. Now, because of the advocacy campaigning, more men are getting involved, and this is really the goal of this campaign in the Philippines, that men will be the face of this particular campaign, because in our office we are all women, and we cannot really do advocacy for the issues of men because we don't really know exactly what are those concerns and issues are. So now we have the first local chief executives, a prominent mayor in our country who are now supporting this campaign, and also one of our trainers now to train fathers to implement the manual. And the men there are also our future trainers and advocates. Now, it also increases private and government partnership. Advocacy is really relationship building, and even winning friends to join your advocacy. So we have now the Department of Social Welfare and Development. We are now working with them to develop a gender-neutral and gender-specific programs and services for boys and young men. And the Department of Education is also on board. We are now developing a mental TV series production. This is using the traditional media because we want to reach the farthest part of the country. We are an island countries. So therefore, using TV would be our means now, and even social media will be our means to communicate again. We are not yet done this with this campaign. We have the law, but the law is still there. We have social norms to change. Then again, as a Catholic country, we also work a lot with the church. And knowing that most of the cases that most of the cases that would come out from the church are also boys. These are cases of religious misconduct. So we are happy now that the church are open to work with us, and they are now including this issue in their church child safeguarding policies and intervention. And of course, we've been working with the Department of Education to do prevention education program, and the issues of boys are now also embedded in the curriculum system of our schools. But there are still challenges that we are facing, and one of these is the limited community-based mental health support for boys and young men. Our goal is to make mental health and well-being services available, accessible, affordable in the community so that our boys will be encouraged to really come out, for them to know that there are services available out there and it's up to them to access this. So I hope one day these services will be developed. That's all, and thank you so much.
Thank you, Zenaida. That was interesting to see how patterns connect and how the issues of masculinity in Philippines are not very different from the issues of masculinity in India, although each intervention and each solution has to be more culture specific, but the difficulties are common.
Yes.
So to hear more from about this, First Step Cambodia is being represented by YM Shamaroon, if I've got that right, sir. Thank you for being in India. And Mr. Shamaroon has been working on the issue of safe environment for all children in Cambodia. He has an undergraduate degree in science from Malaysia and a human resource management degree from Cambodia. And he works with international alliances of civil society organizations to improve the lives of vulnerable children and families. Thank you, sir, for being here. And you have 15 minutes. Thank you.
Good afternoon, esteemed guests, professors, doctors, and I would like to pay my respect to Dr. Acha, Madam Rita, for this wonderful occasion and conference. So I'm not going to share what Zeni has shared, even though, like, if you go through my slide, there may be some duplication. So please do not focus on the slide. So I'm trying to figure out the remote control. Okay. So what I'm going to share with you here, there will be a combination of the research findings and the work at First Step Cambodia. So, you know, actually, this is one of the turning point for boys and sexual violence. 12 years ago, when, or more, when we started First Step Cambodia, when we talk about sexual violence against boys, people laughed. And people say, this is ridiculous. Boy can be abused. And 10 years later, we still hear similar reaction when we talk about sexual violence against boys. So I'm going to skip this slide. So what do we find in Cambodia in terms of gender relationship, We try to understand what is actually the rationale behind laughter, behind the lack of belief. What actually make people find it so difficult to believe that boy is vulnerable to any form of, violence, not just sexual violence. So, when we conduct this study, and we learn that there are two perspectives around gender relationship. One of the perspective is very helpful, is very positive, that boys and girls should be treated equally or the same. And they also talk about boys and girls should be sharing responsibility at home, at work, making monies and so on. But there is also other perspective about gender roles. That boys should be provided more freedom. They need less protection. And, meaning that girls are weak and then need more protection, need less freedom. So that, impacting both boys and girls in terms of this perspective. Also, in terms of masculinity, Zeni has presented, that boy must be brave, strong. But in the context of Cambodia, also boys are treated as gold. Gold is very expensive, it's very valuable. Yet, meaning that they never lose any value if boy experience sexual abuse or violence. They never lose their value. They're not going to be pregnant. So why bother? Why do we care? And boys are the perpetrator, not victim. And I hear this is very common also in other countries, that boys are tough, brave, and not really victims. And we also have some very powerful slogan in our culture, in Cambodian culture. Boy, don't cry. And being a tough person, you better to bleed than cry. So if you have anything, happening to yourself, if you go through difficult time, tough time, you keep it inside, you don't show it. You don't cry, you don't show your upsetness. It must be in there. So this, again, with sexual violence, if you experience it, keep it inside. You don't share it, you don't seek help. Because that's the sign of weakness. So this is a very powerful photo, and we also use this for educational purposes. You see this boy, he looked like a gold boy. State authority just, also believe that boy is a gold. So if he experience abuse or violence, he doesn't need any support. He doesn't lose anything. So looking at sexual violence in Cambodia, so far, there is a limited understanding. As you know, that not just in Cambodia, as Zeni presented, we still deny that sexual abuse or violence against boys exists, and it is impossible. And there is also discrimination against boys and family who actually experience sexual violence. Often people will laugh at, people will criticize the boys, and sometimes stigmatize them, call them gay, call them, all the word that they want to call to, make the boy even more vulnerable. And some of the, children, other children and neighbors can also sometimes isolate this family and boys for not being a real boy. And this actually make the impacts or effects of the violence become worse And come to and also the context of sexual violence against boys by women can be seen as acceptable. And this is one of a very powerful quote and a very common quote that we hear from social workers, from general on average community adult, as well as government official. They will say this boy must be very lucky to have experienced sex with a woman. And usually there is no legal implication toward this woman. Because of the narrative of our law in Cambodia, almost like sexual abuse is, boys toward girls, men toward women. So challenges in terms of services for boys. So far because of the limited understanding, the lack of belief, then often the services for boys is very limited, almost not available. And so far only First Step Cambodia provide these services, provide therapeutic support and counseling to boys. And generally, when we talk to professionals, we talk to service provider, social workers, often one of the reason that they ignore this is that they don't have the capacity to respond. And I would like to share my experience. 13 years ago, I worked in one of the very well-known mental health organizations in Cambodia. And they actually have lots of psychiatrists, counselors, and this is not a criticism. In one of the training, in a role play, I act as a victim of rape as a boy in the role play. And this is a very well-trained counselor, has more than 15 years of experience. When I just disclose as a role play, I disclose that I am a survivor of rape. She shut down, she got very shocked, she stopped talking. And he said, we have to quit our session. I got shocked. I don't know what to say. And in the feedback session, they said, I am a woman. I don't think it is appropriate for me to talk to men about rape. And I don't even think that boys can be sexually abused or can be raped. And that was shocking, but also is that what really remained for many years in Cambodia. Today, if we look at safe space for boys for temporary, for example, if this rape take place in their own home, if you want to look for a temporary, foster care family, there's none in Cambodia. There is some for girls, but none for boys. Even kinship, care by the extended family, people often reject boy. They prefer more girls because people see girl as easier to talk to. They are well behaved. Boy often act out and not really behave. And this is one of the adolescent boy who participate in our research. This is what he say. If I have problem, I don't know where to go. And I never hear about any shelter for boys. And also, other boy would say, I don't want to seek help. Because I know that I'm not going to get the help I need. Many of these boys often experience being laughed at, being rejected, and some of the community member or government official, the police sometimes told them off. And often boys are called a liar, come to the context of sexual violence. And this shut them down. So, how sexual violence affects boys? Sexual violence is a traumatic experience. And it's very traumatizing. The effects can last very long time. It can be a lifetime without any appropriate support, the right support. So, I'm not going through this list. This is a very long list. But boys often have a lot of fear, a lot of confusion. Some of them even confused about their own sex. Am I a female? Why am I abused? Why am I raped? Some of them even have nightmare for a long time. Some of them is even scared of specific figure of a person. One of the boy that we work with, he is so scared of someone with curly hair. And one of our staff with curly hair visiting him in one of the sessions, and he never talked to the staff. He hide in his room. We didn't understand why. We are trying to help. And the only time we found out that the person who raped him was with this curly hair. And they have lots of fear. And this also make them struggle at school. Often the teacher complain, this boy cannot concentrate. No one know why. Because this boy lose sleep. He has nightmare all the time. Sometimes he can get very angry for not really sensible reason. Some of the boy also may stop bedwetting for a long time, and now he start bedwetting, and parents get very angry. Why are you becoming childish again? So many things that they have gone through. And some of the response from service providers, social workers, counselors, us, can also make this experience even worse. Why boys stop going for help? Not just because of being seen as weak, but most of the time when they go for help, they don't get the help they need, they will blame. Some of the officials punish boys for reporting rape, reporting sexual violence against them. This make, life even worse for them. So they often stop talking for a long time. We have a man actually reach out to us when we try to promote the issue, we try to raise awareness of the issue. After 20 years that he never talked to someone, he talked to us. And he said, because no one believed him before. And this can last for a long time. So I'm going to look at, what do we do with this? There are simple tips that we learn from boys. These are some of the things that we learn from our casework with boys, but also from our research. They need somebody that listen to them. These boys need someone that believe that they can also be vulnerable, that they can also be victims of sexual violence. Not to judge them. Give them love. Being patient. Boys are not sitting around in our experience. They don't sit around. We find it very, they don't concentrate. You cannot sit in a counseling session for 1 hour with them. Their focus or their concentration span, 15 minutes maximum. Engage them with activities, plays. That's why I like what Chess mentioned yesterday. Engage them with play. We engage them with ball, playing ball, throwing ball, asking question and answer, drawing. Use activity, games that help them talk, that help them express. And also, confidentiality. Not to share this with everyone in the community, because then this boy will be laughed at. Other kids will not make friends with him anymore. Being gentle. Sometimes we think boys are tough, so we need to be tough with them. No, they need someone gentle. They need someone that respect them. And they are the expert of their problem. Chess, you made it very clear yesterday. We are not the expert, so listen to them, try to understand what they have gone through, what put them in that situation, Why do they behave the way they behave? Thank you. So, these are some of the tips I share, Also recommendation for individual work, engage children and boys in, prevention activity, engage parents. Because sometimes the problem is not just the boy, it's a parent. So parent has lack of understanding. By training them and then engage them in training other parents can resolve this problem, can resolve this lack of understanding. But also casework. Make sure that there is a service available, help them recover from their experience. Community level, making sure that there is stronger child protection mechanism. It's not just awareness raising within the community. There is this body that can respond to child protection, and they need understanding of boy and sexual violence. Because, we can have this body talking about child protection, but it may not be included in the, boy are not included. Also making schools safer, When we talk about, violence against children, it's both boys and girls, not just girls. Religious place. This is a very common issue in Cambodia also when Zeni talked about the Catholic Church. In Cambodia, we have this Buddhist pagoda where boys are placed in the pagoda for learning purpose, for education purpose, but then they are sexually abused. And each case often, involve 5 to 10 boys, victims of, rape. So this is also a big problem. We now have the child protection policy and mechanism within the pagoda, but the reinforcement still limited. So service provider, we need to help service provider understand, have the capacity to respond to sexual abuse of boys. This is why First Step Cambodia, we designed a training curriculum to help service provider understand the issue, but also to help them learn to talk about sex, sexuality. Zeni talk about parents, do not talk about sex, sexuality. But service provider themselves do not talk about sex, they are shy. Social worker, counselor, when talk about sex, their face blush. And then how a child would talk to you when you have this blush on your face? You are shy yourself. You don't use the accurate word describing body part. So national, we consultation. So we look at having a place in the national level consultation or committee. So at the moment, First Step is in the a number of national committee to look at developing training curriculum for social service provider throughout Cambodia, and lessons about sex and sexuality, sexual violence against boys is integrated into that training curriculum. We also a member of the committee of the, the licensing office to provide license to social worker, and we also try to include some of the criteria or the tests related to when we talk about sexual violence against children, make sure that boys is included. And we also join the BUD campaign to ensure that boys' voice are heard. So this is the summary of our research and what we learn from our casework with boys, how sexual violence impacted them mentally, and what we as professionals can do to respond to that. So thank you so much for your attention and your patience.
Thank you so much, Cameron. I think the multiple dimensions that your organization and you are working at is interesting, and you're looking at it from a systemic point of view, especially your work with service providers, and I underlined the word for myself, licensing, and getting involved in licensing based on competency and including the value framework would be a very interesting model for others to look at as well. Thank you very much. It's my pleasure now to invite Krishna Thapaji from Nepal. He's a graduate from Nepal University in sociology, and follows, he established an organization called the Voice of Children, and they follow an approach called the ladder approach. They work in partnership with government and civil society, and they are a part of the National Alliance of Organization working with street children. He's been a crucial member of government bodies and child welfare boards and central committees of the Ministry of Women and Child. Thank you very much for coming here, sir.
Thank you. First of all, I must thank a lot to Rita ma'am, because the place where we are here from many countries and from different sectors here, is this opportunity was actually the result of hard work of Ms. Rita ma'am and the entire team of Butterfly. I also would like to thank Secretariat of Family for Every Child and especially Rajiv Rai. I'm very happy to be here to share some ideas. More than this, it's a very good opportunity for us to learn from different people, and especially about mental health. This is very crucial and cross-cutting issue for everyone. Before going to my presentation, obviously this study was done in 4 countries, so the findings are mostly similar. It's about not only focusing about sexual abuse among the boys, it was about masculinity, about social norms, what are the things in the society, in the community that influence or impose to be a victim sometimes, or maybe sometimes showing harmful sexual behavior, etc. More than this, I just like to focus on the scenario in the country. How is the situation about sexual violence among the boys, and what are the challenges, and also what are the achievements also. I would like to share a story that actually I can say the story of superhero for Nepal, because in 1993 one street child came to the office to see someone and who spoke about what happened to him, and actually it was a sexual abuse happening for a long time, for many years with him. And in fact, it was not only him that was suffering from this kind of incident. So there was a child care home run by the foreigner, and there were 44 children from the street, and they were abusing, everybody were abusing by that person, and sometimes he referred to his friend also. So he spoke to someone else before us, but he was ignored, and in fact he was like nobody listened to him. So when we heard the story, then it was, of course, it was very shocking for us also, because we never heard that boys or male can be sexually victims. So it started from that story, from his story. Then what we did, we tried to register a complaint to the police, and the police became a villain because he blamed us, saying that we were blackmailing to that person for money. So with that big team, including myself, had to, so they put me in a jail with the child for 7 days. And in this in 7 days, it was a kind of huge scandal, because the issue was a link with the foreigner, who was a reputed person. So there was two versions in the media. The one version was like, male cannot be victim, so we were blackmailing to the foreigner. The another version was, see what the children are saying, because there were other children also were saying the same thing. So the another version was, we have to listen to the children at least. So that's how police was ready to do a kind of investigation. So they found some evidence. They understood that, okay, it's happened. And the problem was there was no any law. So what they did, that the first case was registered, but it was under the public offense code. And there was a section, article, it was about unnatural sexual activities, which refer to the sexual activities with animal. So that's the year how and who started this issue was that boys. Then it became a huge issue and started a kind of advocative work, and NGOs also opened the eyes, government also opened the eyes, but it took a long time to move ahead. I have some findings after that moment. Obviously, we did 42 cases against abuser, but none of the decision was in favor to the victims, except one case we did in the country from where the abuser was coming. So we have done some research after this period. So the research was done in different years. In 2001, in fact, there was a research in 2000 also by ILO. In 2001, 2008, and 2010, it was among these two children and the children living in slums area. So 70% of boys who are living in the street are sexually victim, and they have a knowledge about sexual experience by either being victim or sometimes being a kind of influence of abuser, but at the same time showing the harmful sexual behavior as well. And 29% children were victim of worst form of sexual abuse. It means like oral sex or like a sexual intercourse, you can say, because there are different categories defining the sexual abuse in Nepal. 40% abusers were senior boys from the street. And these 70% children who were sexually victim, and 65% were foreigner at that time. And 38% incidents were happening in the street. So mostly children were, where they are living, the incidents are happening over there. There was another research. It's about assessing the risk of exploitation online. It was done in 2017. 72% children they use the internet, and out of this, 80% are boys. So obviously, girls has less access to get such a kind of facilities, we can say, mobile, internet, etc. And 15% children responded that they were sexually abused in online, and 47% were boys. So there was another research in 2019. It was about increasing vulnerabilities that we were talking here. So I would like to add a few things on this study that mostly children, they learn about sexuality is from sibling or peer groups, and recently they learn through television, internet, our friend. Whatever the harmful sexual behavior shown by the children, people that don't pay attention because they are boys. Considering the same thing happened with the girls or by the girls, maybe people they pay attention a little bit, but for boys, they consider as it's normal because they are boys. And boys can tolerate this kind of things. And also, some children said that, yeah, it happened something to me, but I cannot express, I cannot share, because if I share, people think that I'm weak. And if I'm weak, then I cannot take care of my sister or something like this. So there is something already in their shoulder, putting by the society, by the norms, maybe. They also share that sometimes people, they abuse boys if they are not able to have a relationship with the girl, with the woman. There are another other indicator or some data. It shows that we have juvenile justice. There are thousands of reports. Actually, it's supposed to be for conflict with law. If the children are fall in conflict with the law, juvenile justice is supposed to handle this. But in our country, we found that there are mostly the cases registered which are related with sexual abuse. And there are 30% of cases which are related with the children, and out of this, 50% boys are accused as a rapist. So this is also something very challenging for us. What are the effects? What is the mental problem that the victim may face or suffering? The problem is we don't have any research, any study done, not only about sexual violence. I would say apart from small incident like earthquake or a study done in certain a limited group about COVID, etc. We don't have a kind of study and research about the mental health. So in general, so it means we cannot expect that study can have or can be done in near future about sexual violence among the boys, because it will be a less priority for everyone, for the country, for maybe for civil societies, etc. But we have some case story that show that how it's a problematic for the victim. The one child, he was a victim of a pedophile. And he said that I'm confused, either I'm a man or a woman. He says sometimes when I stand in front of mirror, I see with the chika or lipstick with long hair, something like, and suddenly I'm on the reality. So it happens several times to him, what he said. And he said that he's not interested to have any relation with the girls. Because, it's like sometimes he hates women and girls. Another story is a banker. He's a CEO of a private bank. He was a regular listener of radio program which was about child sexual abuse. One day he called and he wanted to have a long discussion. And he shared his story that he was abused by a cousin for many years. And at that time he didn't realize that it was abuse, because sometimes he felt that he's getting fun also. So he was confused. And now he's already 38 years old. And he said that I don't have a good relationship with the family member because everybody pressuring me to get married, but I don't want to get married. Sometimes I feel like, I don't know, maybe I can have a boyfriend, but I cannot because of my reputation. So I was lost with this. But he was not remembering what happened to him during the childhood. So he remembered when he heard several episodes of the radio program. Then he said, I realized that why I am not interested with the girl, why I am not interested to get married, etc. So he was really, he needs support, but he was really afraid to get service. Then we had a kind of counseling for long period through the phone. And now he think we never met him, just one by the phone. He think now he's perfect. So this kind of thing is a proof that how victim can be traumatized and suffer with the stigma. And another story that is a person who is a senior film director. In fact, he was directing a movie about sexual violence to the boys, among the boys. And he did very hard work. We provided several kind of orientation and training to the artists also, to the entire team member of the film maker. He understood everything. He wrote a kind of narration. We provide some inputs. We gave feedback, etc. So he did very good job. We have this movie. He did very good job. But after 2 years, he came to see me and he said that I don't know my work was appreciated by the Nepali society, by you or not. But for me, one thing I realized that I never was able to share this problem, but I understood that I was a victim of sexual abuse when I was maybe 7, 8 years old. So it means like it takes very, very long time to come up or cope from the situation that has happened to during the childhood. And most of the cases, I think we rescue more than 280 boys who were sexually victim, and 90% of the victim who got psychological support they recover. Some cases we have, it's really painful to share, that some of them they suicide. We knew that several times they attempt for the suicide, but we are not able to save their life. What I learned from my last 30 years experience working with protecting boys from sexual abuse is sexual violence among the boys is more complicated and more challenging, and it's really difficult to provide support. It's because most of the cases it's happened through the long grooming process. Those who suffer or become victim through the long process of grooming, it's really difficult even to identify the cases, provide the support, because everybody, I mean, all the victim has the same, had to cross some, from the same situation, but for boys, it's one complicated and painful and difficult situation they have to suffer is they have to fight with themselves. Because I was saying that one guy saying that I don't know, I'm a woman or a man. It's this is the fight that they have to do with themselves, because somehow their image was built by the person, abuser, through the grooming, that it's a normal, it is doing by everybody. If you want to be a kind of like me, or like a male, or like a person, or like a famous person like this, or like him, then you have to do this. So at that time they don't know. Sometimes they are in the borderline. They are enjoying also, but at the same time they are confused also. So this confusion and this conflict goes until that period when they didn't know that, oh, it's an abuse, or it's a victim, it's a victimization. That's the one more thing. It's challenging to protect boys who are already victim through the grooming.
We're running out of time.
Thank you very much.
Thank you, Krishnaji. That was through your narrative of so many people and your own experiences, you've been able to create a framework on which solutions have to be based. And your experiences with solutions have been interesting, and the fact that intervention leads to recovery is an important learning, although bad intervention does not lead to recovery as well, and sometimes interventions can harm more, and one wonders sometimes as to what intervention is important and what intervention is not important, and we will discuss that more as we go along. Housekeeping, we are at 1 o'clock, we started late, we have 2 more speakers, and both of the speakers will speak together. So 15 minutes, and then what time do we want to go for lunch? It's 1 o'clock, 1:05 right now.
So we need to listen to you too.
I will evolve my conversation. So 1:45, great. I should have asked the audience as to how hungry they are. Okay, I think we have 2 interesting perspectives from India, from Butterflies, Mohammed Sharif, who's got a master's degree from Pondicherry University and has worked at the interface of education, child protection and mental health, and community mobilization. So perspective from Butterflies brought to us by Mohammed Sharif, and Priyanka Lakra, who is at present a program officer in a child protection mental health program of Butterflies, and has a master's from Christ University and has 6 years of experience in, again, education, protection, and mental health. This interface is an interesting interface to hear about. Thank you.
Good afternoon, everyone. I and my colleague, Mr. Sharif, are honored to be standing here in front of you all. And I first want to thank Ms. Rita ma'am, who gave us this opportunity to stand and make this presentation on behalf of Butterflies. So, as my previous speakers have already shared about the studies, Butterflies was also part of the study, and I will just quickly go through it because already my fellow speakers have talked about it. So these were the questions which the research talked about. It was about gender and masculinity. What does it mean to be a male child? And what are their lived experience in the context of sexual violence? How are masculinity and sexuality socially constructed? It also talked about sexual violence. What are the links between the dominant notions of masculinity and sexuality and the sexual abuse of boys? And also talked about the existing interventions and the challenges they encounter and how are they resolved. So these were the findings which we have already talked about. I'll talk about boys who experience violence are ridden with guilt, shame and anger, that they could not defend themselves from sexual abuse. And in majority of cases, it was known person who was the perpetrator of the crime. The first three was already talked about, so I will not speak again. When we talk about the mechanism, in India we have POCSO Act, which is gender neutral, but still there is support system is lacking. And this is because of the lack of acknowledgement and acceptance of sexual abuse of boys, which creates barrier in reporting and investigating. Now I'll talk a little about the barriers. Through our experience in working with boys, it shows that boys feel embarrassed and ashamed and less of a man. They feel that if they share it with their friends, they will make fun of or they will be targeted. And because of this acute shame, boys are unable to express what have happened to them. And just as girls, boys also face an issue in expressing or using correct words when sharing about sexual abuse or sexual violence. Like when they share, they say, something bad happened to me. मेरे साथ कुछ गलत हुआ था. They will not use the words. Boys are also afraid that no one will believe them if they disclose about the abuse. Even they are afraid that their parents, their older siblings who are there to support them, their peers, will not believe in them. And they will consider them to be weak. Now my colleague will talk about the effects on emotional well-being of boys affected by sexual violence.
Thank you, Priyanka. So, as social work practitioners, our experience of working with boys has shown that sexual abuse has a severe negative impact on the emotional well-being of boys who have been sexually abused. So when this abuse happened to the boys, there is a devastating damage to their ability to trust anybody, and they find it difficult to maintain relationship because many a times what happened, the abuser is someone close to the boy who has been sexually abused, with whom he had a trustful and caring relationship. So when this relationship turns into abuse, they find it difficult to maintain relationship and have trust someone or others. And there is a deep sense of shame, guilt, and worthlessness. And they feel fear of a particular person, place, or darkness. Even going to the new school, joining new school, new groups, they find it difficult, and the new faces seems to them very, threatening, very, stressful. So they also have negative views of sex, sexual dysfunction, and misconceptions. And it also affects their self-esteem and body image. Because the boy who has lived experience of sexual abuse feels that what is it in me that made that man to sexually abuse me? Is there something wrong in my body? Is that I am not a manly person? Is there something that I am not a strong person? So the continuous thought that goes in his mind, questioning himself about his own body. Next. So when this abuse happened, so in order to cope with that abuse and to forget that the trauma, most of the time what happened, the boys use maladaptive coping mechanism like using substance, alcohol, and there is a tremendous amount of aggression and irritability or tantrums, and they also feel fearfulness, anxiety and depression. So when sexual abuse happened with the boy, the thing he feels is that how do I speak about this? How do I share it with my parents? If I share, they will be ashamed of me and themselves also. And how do I share it with my friends? How do I know that my friends will not tell it to others? Then they will target me. They will make fun of me. So the amount of trauma they are going through this because of this sexual abuse, it's very, very horrible. And also self-harm, self-injurious behavior, and also suicidal tendencies. Now my colleague Priyanka will continue a few points. She will highlight.
So as Mr. Sharif said that the trauma the boys go through is very much, and that causes regressive behaviors like bedwetting, clinging behavior with someone they trust. They don't want to leave them. And thumb sucking, isolating themselves in social gathering or in a group, and does not want to engage themselves in activities which they had liked or whatever activities. There is recurrent nightmares, disturbed sleep patterns, and the boys are terribly ashamed of themselves, and just as Mr. Sharif said, they start questioning about their own body image, their own identity, and also question themselves, what is it in them that led to sexual abuse, or is there something wrong in the way he conducts himself that attracted the perpetrator? Hence, sometimes to hide their own body, they start wearing many layers of clothing, no matter what the weather condition is, so that they can, they feel that their body has something to do with it, and so they start hiding them. And I just want to illustrate a case of a boy in Delhi only. Last year, the boy committed suicide because he was sexually abused by his classmate, because he was seen by his classmate as weak and as easy target to sexual violence. The boy did share this incident with the mother, and the mother did support him, but the school did not. And then in course of few months, he committed suicide. So this tells us about how much trauma goes through in the minds of boys who face sexual violence, and that there is no space to talk about it. And no support is given because they don't know how to give, and maybe because stigma is there. So,
yes. So, when a boy is sexually abused, it's not only that the boy is affected, but the whole family, the entire family also affects because of this abuse. So when family members comes to know about that their boy has been sexually abused, they have excessive worries for the reputation of the family and also for the future of the boy. There is also they have family discourse, fights, and there is a blame game between husband and wife, and there is a grief in the family, and family have guilt, especially the father. He feels that he is not a good father, as he was not able to protect his son and the reputation of the family. So it's not only the boy, but also the entire family go through the stress and anxiety. So in Butterflies, it's not that we only work with the boys, but also we work with the families also. And And also, wherever possible, we group work sessions also conducted with their peers. In our experiences, through our experiences, some recommendations are to address the sexual violence against boys, to address the negative social norms that perpetuates patriarchal values and notions of masculinity. And because children spend significant amount of time in school, therefore, school should have professionally trained counselors having experience in dealing with the boys who have lived experience of sexual violence. And community-based care and protection services should be available for boys and girls. The professionals providing services for children should be sensitive and informed that sexual violence happens against boys as well, and support should be provided to them as well. Addressing knowledge gaps on the boys affected by sexual violence through further research. And also our media to change the narrative on child sexual abuse, that child sexual abuse is gender neutral. So, Blue Umbrella Day campaign, as my other colleagues also talked about it. So, as was found in the multi-country study, sexual abuse of boys and lack of acknowledgement is a global issue. Therefore, in order to address this issue globally, Family for Every Child launched the Blue Umbrella Day campaign on April 16, 2020, which is an annual event. And where 31 countries across Asia, Africa, and Latin America participated in this campaign, and Butterflies was also a part of this campaign. The aims of this campaign is to draw attention to the need to provide appropriate protection to boys to support their well-being. And there are some messages from the campaign. You can read on the screen. So with this, I'm just ending my session. Thank you.
Thank you, Priyanka and Mohammed Sharif, for, I think, an explicit summary of mental health impacts that a child might face, and the attribution of blame to oneself and the difficulty that one experiences with a system that does not understand how all children can be abused, not just girl children, and it's important to underline that. I'm going to stand up now.
I just wanted to show that this is a painting done by a boy about what a boy goes through.
Right. I'm going to take some time, maybe 15 minutes or so, or 20, depends on how carried away I get. And how hungry people are. And because we need to have some interaction, 5 minutes of interaction as well. I've stopped using, Nimesh is there. Thank you for coming, Nimesh. So I've stopped using a PowerPoint for this work because I realized that I first made a PowerPoint about this in 1997. And I haven't changed it. I felt embarrassed that I had to continue to use the same PowerPoint. PowerPoint has undergone about 25 versions in software upgrades, but the domain knowledge expertise on that unfortunately remained the same. So because I felt so embarrassed about using the same PowerPoint and the same words, I've stopped using it. But some things are important and need to be underlined. There are patterns that connect. So there are things that are happening in Philippines, there are things that are happening in Cambodia, there are things that are happening in Nepal, Bangladesh, Pakistan, anywhere, India, Baroda, Gujarat, Delhi. There are things that are similar. What is the similarity in the patterns that connect? One, we live in a society where the discourse with children does not exist. Children do not have spaces for communication, period. Forget communication about sex or sexual abuse or identity. They don't have spaces to communicate. Violence is normalized and prevalent in every aspect of our life. There is violence in our education system, there is violence on the street, there is violence in our media, there is violence on Twitter. When violence is, there is violence in every aspect of what we do and experience. When violence is so normalized, one form of violence is so normalized, then trying to break it into sexual, physical, psychological is trying to get granular for our own intellectual satisfaction. Violence is violence. And our acceptance of violence is what we need to address as primary solutions. The micro solutions are important. The fathers communicating with sons is important. The caregivers being trained is important. I don't deny that. Competency-based training is important. Yeah. But I think the primary change needs to happen in the way parenting is addressed, the way education transpires. I'm not using the word pedagogy, but the way the education is conducted. There is bullying by teachers of the students. There's bullying of the students of each other. There's bullying of the teachers by the management and the controlling authorities. If you are being abused yourself, and if you haven't felt that you can stop the abuse for yourself, how would you stop it for somebody else? So we need to be real, and the reality has to be that we need to change the way we parent and the way we educate. That's the bottom line of what I've learned in the last 30 years. The rest, believe me, sitting across a table in a psychiatrist or a psychologist's room is a good way of labeling people. It's not a good way of reclaiming life. It is necessary. It's a component of what you might do. But if you have to reclaim lives from trauma and from violence, we need to address things in the community, in our lives, in our own minds. Before changing others, we need to start looking at how we address violence in our lives, and how we address the normalization of violence around us. Yesterday, I live with two small children. One of them is 6 or 7, and the other one is 12. I keep forgetting that they are growing. They're growing so fast. And they were talking about violence in Manipur. And one of the older one was saying that she's unhappy because her friend is unhappy because her family had to hide in Manipur. And the younger one said, but why are bad people burning houses? She had only, she saw images of, and two of her friends who are from Manipur, this is a school which encourages diversity. Two of her friends who are from Manipur, she asked me this question, can those two friends come and live with us? I said, but they have their own houses, why would they want to come and live with us? But their houses in Manipur, she can't distinguish between the house in Manipur and the house in Delhi. She's 7. The whole concept is merged. To her, what's happening on the TV screen is happening in her friend's life, is happening to her, and it's very real for her right now. It's not very distant for her. She is traumatized by that, and she is that's one layer of trauma, and that's one layer of helplessness that's already been formed in her mind. How do I challenge that layer of helplessness? I'm a good psychiatrist. I work with children. I know how to communicate with children, hopefully. But I didn't have an answer as to how to address her helplessness that's being formed just now. And how that will get converted into disempowerment and risk for abuse later. Or even now. Who knows? So, is the discourse not about difficult things? It's the discourse about things, people, lived experiences, life. We use these words very narrative, lived experiences. We use these words commonly. But when we actually talk about experiences, we talk in third person, as if we're talking about cases. A lived experience cannot be narrated as a case. A lived experience has to be felt. And if there were a course in empathy, and if empathy could be trained, if it's a skill that could be learned, and if one had the patience to do so, that's one skill that I would train every teacher, every parent, every child, every doctor, every nurse in. And then build upon that. But empathy, can you train empathy through a PowerPoint presentation, or can you train yourself about being empathetic by having experiences of empathy? So if we start, I'm sounding a bit philosophical and not scientific right now, and not replicable right now, but unfortunately, if you do not build experiences of empathy around you, you will not be able to challenge the normalization of violence around you, and you will not be able to address how boys are dealt with in the various systems that they come in contact with. The whole concept of the protector, and if we don't stop thinking in terms of binaries, of the protector and the protected, of the man and the woman, of the abuser and the abused, then we will continue to label people and try and fit them into holes which their lived experience or narrative cannot fit into. Specific solutions, definitely relook at how labeling, how categorizing, how excluding our education is, and address that rather than addressing the curriculum. And snipping it off from here and there. Address how it actually can become inclusive and accepting of each other, and listening of each other. Solution number 2, structured parenting programs for all parents whose children are in school or not in schools. I don't believe in this safe touch, bad touch, good touch kind of training or life skill kind of training, because what do you do with it? You know, a 2-year-old child or a 7-year-old child, if she can understand what's happening in Manipur, can understand good touch or bad touch without being taught. That knowledge is already being transmitted to her through the protectors in her environment. But protectors, unfortunately, can also become the abusers in her environment or his environment. So what is required is conversations with children, stories that they can tell, spaces to tell stories in a safe manner. Next, all child care protection professionals should be trained in basic skills of empathy and counseling. All graduates in psychology, graduates in social work, graduates in medicine, graduates in nursing should have training on mental health, which is substantive, and should have skill-based training on mental health, not just about trauma, but about mental health in general. And not limiting to only diagnosing mental illness, but to listening to people and helping people in a structured manner. All postgraduates should have advanced training, and then you build on top of that a trauma-informed cadre. Right now we are trying to build a trauma-informed cadre which is also learning many other things without having too many skills transmitted to them throughout their careers. Theoretical training for most of your life, 2 weeks posting at the end of your training. That happens across the world, unfortunately. We spend too much time diagnosing, assessing, talking about problems than learning skills for solutions. Those are my solutions. Thank you very much. I think we are open for questions and comments for about 5-7 minutes, or till hunger calls us. Yes, please. Please give your name and say your question.
Hello everyone, am I audible?
Yes, please.
I'm Shomdatta and I have come from Sukaria organization. So I am working as a project coordinator of education. I was in West Bengal and I was working there on adolescent and child protection as well. So I want to share a few feelings which I had. So number one, what I felt is that as a society, to protect children from such predators, is that we need to dissociate the concept of negative impact of body. Okay? So when we do that, what will happen, even if a child is facing violence like that, sexual violence, he or she will not question himself or herself that, is there something wrong with my body? That sense needs to vanish. And another thing is that, as Thapa sir was talking about the impact of internet and TV. So, like media is playing a massive role of the impact that it is creating. And children is, watching mainstream media where movies and songs are shown like this. Children are learning through that. So we as a society, I feel we need to focus more on much more constructive things that can be done for children instead of degenerating
Thank you, Shomdatta.
Thank you, sir.
I have a friend who says this. I'm quoting a very good friend of mine, Shekhar Sheshadri. And he says that violence is not against the body, it is against the person.
True.
And it destroys and demolishes a person rather than just the body.
No, so
or the image of the body.
Yes, what I was saying is that then the child will not have that impact. Like that feeling that, my body was harmed.
More conversations on this as we go along. Madhu.
So, I had lots of questions, but I think Dr. Achal has put the context in very beautifully, because I have the experience of being a teacher and after that being a mental health volunteer. And I think what he summed up is that it has to be parenting, it has to be the school structure before we really get into what happened, body image. Because I still remember those two books, the red book and the blue book, which were, that good touch and the bad touch, which we used for so many years. But the generation today knows exactly what is happening to them. So I think parenting and schools, and also I think I would also like to add here the residential schools, especially the hostels. There's a lot of sexual abuse, but how much of it gets, looked into is also very important. That's it. Just an observation. Thank you.
Thank you, Madhu. I think I would like to add and bring in the panelists here because there was a mention about religion and institutions, not just residential schools, but wherever the child is in contact with institutional formats, which can be protecting, are supposed to be protecting, but become exploitative. Those are important things to look out for. Sharman, do you want to kind of come in on that, or Zenaida?
I think you raise a very important point. Any form of institutionalized anxiety need to be looked into, and awareness is not enough, but put in a system where children are protected, and where also when there is concerns, incident, there is a proper response in place. There is, for example, like in each of these institutions, there should be, focal point where children can be reported, but also has the capacity to respond to children in sensitive manner. Actually.
If I may add, in the Philippines, we are promoting to deinstitutionalize all services within the institution because one, in our cases that we receive, 60% of them are the abuses occurred inside the institutions because they are children, they are bored, and most of these cases are also committed by children. So inside the institutions, they are too bored, they have nothing to do, so they resorted to sexual activities and sexual coercion. So therefore, institutionalization is the last recourse, and we are very strict to recommend sending these children to institution without any strict screening. And second, I think before seeing the school as our partner in terms of child protection, I think it is really a challenge that keeping children safe must begin in homes, in our homes. So parents must do this. We have to really work so hard because we cannot trust our children just in schools or for teachers because teachers are also so overworked. We have also to empathize our teachers. They have other things to do. But as parents, it is our main responsibility that we ensure that we know how to protect our children before they go out to schools and anywhere. So that's it.
Thank you, Zenaida. Two more questions here from Tejpur, ma'am, and at the back.
I'm Sonia from Tezpur, a psychiatric social work professional. Just a statement, and just that from Philippines, is it that there's no sexual abuse among girls? We seem to be protected. I'm sure that if we were girls and we were women in Philippines, women seem to be protected, right? Does it mean that, there's no abuse among girls? I understand that your work is mainly among boys, but I'm sure it's also among girls. I don't know, but you must enlighten us.
Okay, thank you for that question because it will give us a context on why we are doing advocacy to protect boys as the way we protect girls. For clarification, CPT-CSA, our organization, is working both girls and boys in the past almost 30 years now. And the reason why we are highlighting issues now about boys because these are issues that are highly unreported because of the social norms that we have about girls and boys. And we have to acknowledge that in the past 30 years, feminist movement is so effective in coming up with our agenda. I'm a feminist advocate too. And we are very strong in terms of really promoting the care and protection of women and girls. But after 30 years, I think we have to start reflecting and revisiting the way we define gender this time. And we are also asking ourselves, have we done something positive in the past 30 years? Why is it that these issues are still, from my eyes, who has been here for so many years, it seems that our work is still the same. So therefore, this is now high time also for us to redefine the strategies that we had in the past without, moving away from our core of protecting everybody this time. And I think we have now to see, we have to add gender equality. We have to add another term, which is gender equity. And I think this is how we can also explore that we can fight violence against women and girls, maybe in another form of intervention. And we would like to advocate that we have now to work violence against human being or a person, so that everybody will be included in our conversation and dialogue. And men has been there for so long being treated as the offenders and perpetrators. And it's true, 80% of the perpetrators are men, but we have to ask ourselves why. Can we help men? Can we reduce this 80%, at least 50%? So we have to work with men and address men's issues for the care and protection of children and women. So we are not dissecting or separating the two issues, but we are here to highlight that we have missed a certain group because of our strong advocacy of a certain group. So therefore, no one should be left behind in terms of this campaign and intervention. So thank you so much.
Thank you for clarifying, Zenaida. Last question.
Yeah. So my name is Gayatri. I'm a research scholar at Department of Social Work, University of Delhi. So my question to this August theme is about patriarchy. So when the whole conversation was happening, I was thinking about one case that happened down south in Kerala, wherein a girl who was going to 9th standard got pregnant because of her own father, and the mother chose to disown the girl and not the father, the husband, because the husband was the provider for the entire family, and they had 2 younger boys who needed a father. So this way, I think somewhere the reporting, the disowning is happening from the household level. So my question was, patriarchy at the household level is a major cause where adolescent girls, boys are not able to report such cases to the, open, right? So in real terms, the whole ecosystem of patriarchy and patriarchal thoughts within a different generation that where we are from, like in a different generation, my father, my mother, or her father, her mother. So from there it is getting, passed on intergenerationally. So what can be done for that? What could be a solution for that? I know it is a long road to go, but still, where can we start with respect to changing the behavior of parents? Thank you.
Right. I think this is where we need to become granular about patriarchy, because if we then label everything because of patriarchy, then the solutions become very, very insurmountable. Krishna ji, any last comments from you, and then we can close. Any last comments from Krishna ji?
Actually, generally, the issue I'd like to highlight, we're talking about sexual violence among the boys. It doesn't mean that that we are not working to protect girls from sexual abuse. I know that globally there was a report of Therapeutic International that out of 4, 1 girl, and out of 6, 1 boy are sexually victim. So it's so that there is the issue of boys also should be addressed, because that issue is it's not commonly addressed by the society in the country. We can see that in Nepal, and just we were sharing the findings of this study, that even there is incident and parents and the people are aware that's happening and they don't care because they need to support them because they are men, they are boys. So that's the issue. That's the reason why we are just raising this issue as a champion.
Thank you everyone for your patience. I think lunch is ready.
Thank you, everyone. Before we break for our lunch, as we are delayed by 20 minutes, so would you like to come back and resume at 2:40 or 2:30? 2:30? So we agree on 2:30? So we'll come back having our lunch sharply at 2:30 then. Enjoy your lunch. Bon appetit. It's time for the panel discussion 2, second panel discussion. I apologize for the delay because there had been some issues with the name tags print. We have given them the right list, but yet they have misprinted the surname. So we had to run and get it changed. So I would request all the participants to please be seated. The title of this session is Digital Safety in Navigating Internet and Social Media by Adolescents and Children to Prevent Mental Health Crisis. So I would request the chair and keynote speaker of this session, Dr. Manoj Kumar Sharma sir, Professor of Clinical Psychology, NIMHANS, that is National Institute of Mental Health and Neurosciences, Bangalore, and our panel speakers, Mr. Kanan Krishnaswamy sir, former communications manager at George Institute of Global Health, and Ms. Ambika Pandit, senior assistant editor in the National Bureau of the Times of India in Delhi, and Mr. Siddharth Pillai sir, co-founder Rati Foundation, Mumbai. Thank you. Now I would request Mr. Varun to greet Dr. Manoj Kumar Sharma sir. I would request Mr. Hassan to greet Mr. Kanan Krishnaswamy sir. And I would request Ms. Richa to greet Ms. Ambika Pandit ma'am. And lastly, Mr. Manoj, I would request you to greet Mr. Siddharth Pillai sir. Thank you all for your presence today. The chair of this session is Dr. Manoj Kumar Sharma. He is the professor of clinical psychology at the National Institute of Mental Health and Neurosciences, Bangalore, Karnataka. Dr. Sharma is credited to start India's first tech de-addiction facility called SHUT Clinic. That stands for Service for Healthy Use of Technology. He is a member of World Health Organization Group on Addictive Behaviors and Lancet Group on Gambling, recipient of World Health Organization Fellowship in Tobacco Control and Indian Council of Medical Research Department Health Research Senior Scientist Fellowship. Dr. Sharma has received national and international funding for work in area of tool development, addictive behavior and intervention for gaming. He has 180 research papers on his credit. He has brought out articles for public awareness in print media and credited to research papers in technology use in national and international journals. A warm welcome to you, sir. Sir, just a request before we start with this session, we would like to show the paintings made by the children that expresses their feelings. Thank you. Sir, now I would like to hand it over to you to chair the session.
Good afternoon to all of you, and thanks to the organizers for allowing me to share my experiences in this area, and as well as giving me a distinguished panel for discussion on various issues. I thought I would introduce in the beginning so that we can have a flow of discussion. I would welcome Mr. Kanan Krishna Swamiji. He is a freelance journalist and communication consultant in Delhi, and he has around 35 years of experience in media, communication and development. His journey started as a journalist with Hindu. He has worked as communication head at Plan India, Oxfam, and more recently with George Institute of Global Health. And Mr. Kanan has also is a pioneer in adapting the critical appraisal skills for research developed by Oxford University to critically analyze the media and communication industry in the health sector, and launched the Media Doctor Pilot Project in University and Academic Institute of India. Welcome, Dr. Mr. Kananji. And we have another panelist, Mrs. Ambika Pandit ji. She is a journalist with over 2 decades of work experience, and she has written extensively on various dimensions of human development, with special focus on subjects related to child rights, gender, tribal communities, minorities, and concerns of LGBT communities and persons with disability. And she got number of national and international awards also. The best one was she was conferred with Excellence in Journalism for Social Justice, an award by Global Social Service Society, continuing for her work on these issues. And she is currently working as a senior assistant editor in National Bureau of the Times of India in Delhi, and the role, basically for the role of mainstreaming media in promoting mental health. Welcome, ma'am. Mr. Siddharth Pillai is an old colleague, so I think pleasure to see you again. And he has more than 15 years of experience in working with non-profit organizations across India. As Rati Foundation, Mr. Siddharth has taken forward digital safety, advocacy, and resource center activities. And he has also been associated with various international and national organizations. And the important one is UNESCO Asia Pacific one. And he is also has curated the Cinema of Resistance package for World Social Forum for 2007, and he also has a greater interest in digital safety for children and adolescents using internet and social media. Welcome. So basically, I think today I will just and this is the. Going to talk briefly about how technology use affects the mental health and its impact on various domains of mental health. Though I think this is a topic which is not related with core psychological issues, and it is a topic which all of us do face, and all of us at some point of time use technology as a method of coping also. When I'm saying coping, it can be to overcome boredom. It can be to overcome loneliness, because children as young as 6 or 7 years also suffer from loneliness, because now a single child family, working parents, not much time is there to spend in the family context, which is a talk which is from the morning onwards, that family should spend quality time with the children. And then it can be a stress reliever for any sort of situation. It may be stress, it may be depression, it may be anxiety, or nowadays even I think significant major psychiatric disorder, even psychosis and other things, it is coming up as a method of expression, which may not be the topic of today's discussion, but I think that's why I want to highlight it is affecting all sections of the society. So what happens, especially if we want to highlight, this is I brought out this adolescent case for your attention. like 15-year-old boy, single child of a upper middle socioeconomic status, nuclear family, got access to all modern devices at the age of 9 years. 9 years I am taking still later is nowadays 5-6 years child also has. So over-involved, permissive parents, mother is more over-involved in the things, and develop the preference for gaming from the age of 10 years. Started playing from the age of 8 to 10 hours a day, and so each game leads to various awards, rank and other things which become a reinforcer for them. Because nowadays children as young as 11 and 12 years says that we don't need education. I am earning 2,000, 3,000 per week. If I continue to work on my skills, I can earn in good measure also. So why should I need 12 years of education, graduation and other things? People wants to build up their games and other things. They feel it can be learned through YouTube. So why I again need? So I think this is an ethical dilemma. Though gaming is a career also. I'm not saying that gaming is bad because e-sport is another emerging industries. But what proportion of people will go into e-sport as a career still is a questionable thing. So same thing this boy also has. He wants to develop his career in gaming, leading to significant amount of time spent, 10 to 12 hours a day on gaming platforms. And that is what we call binge gaming. If anybody playing more than 5 hours in one stretch, then we say it's a binge gaming. And again, another phenomenon which all of us as adults suffer from is binge watching. All of us have a habit of watching 2 or 3 episodes if you are watching on show series and all. And if it is you are using your screen more than 120 minutes in one go, then any one of us can suffer from binge watching also. The criteria is very mild, but I think this is a criteria till now has been given till it get revised in Indian context. Because I think there are some different definition of drugs in different countries. But when it comes to Indian context, we have to revise it. But still, we have not revised it. We are working on it from NIMHANS side. But still, this is the criteria we are following. And this boy also has a history of ADHD and conduct issues, which is another comorbidities which comes up. ADHD, where people say other tasks, inattentiveness comes up, but when it comes to mobile and other things, they are able to sustain for a longer period of time. Again, most of the parents say it's like any kind of addiction. Forced rehabilitation will work, but this is not. Because technology, we promote control use, healthy use. We don't promote abstinence until it becomes very significant for a particular case. And then it also leads to family disturbance, depression. And sometimes the question family disturbance comes that am I a good parent? Because sometimes the mother feels that since I was working during his early period of development, I didn't give that attention to him. Or sometimes the mother has such a guilt that this was not our planned child. Because I carried a lot of negative feeling. Is that the reason for him to develop preference for gaming and all? But we don't know. These are the reasons. But I think these are the guilt where modern parents feel that how to manage. So I think briefly we will talk about other issues also. So I think what is the reason for excessive use? I think if you see normal person, normal adolescent check the mobile phone 60 to 70 times a day. I think it may be more than that also. And every time if you are devoting 2 to 3 minutes, it takes away 300 to 400 minutes from your productive life. And you may not know that this much time I have spent on my mobile. So what is the reason for so many time we are checking? It can be accessibility. 24 because of COVID time it has become more, and especially most of the parents are now saying that because once the child got access, he doesn't want life without mobile phone. Acknowledgement, parents and the real world takes time to acknowledge any kinds of efforts, but mobile phone, social chats, you can get acknowledgement within a minute. That's why another thing. Affiliation. People feel I'm not getting good time in family context, but when I'm with the friends, I have my time. So that way, and the gaming also, children say that I have so many friends with whom I can share my feeling, with whom I can talk X number of hours. And so that way it fulfills my need for affiliation. Leisure time, earlier leisure definition was different, but now it has become digital leisure time. People want to spend time with YouTube, social media, or any show series. So again, it means we have to change our definition of leisure time. Free time again, entertainment, excitement, euphoria, all these things. And other things which comes up is coping is psychological, whether it's a management of distress, mood states, boredom, loneliness, all these can become a coping method for young children, adolescent or adult. And last is people who are on social media, they start considering the social media contacts are their support system. which is a significant change. Because earlier we used to talk to others to see that support system is there, but nowadays we feel so many contacts are there, that is my support system. That's why I think whenever there is any criticism, anything happen, they feel I'm losing my contacts, people are not following me. So, but when the study was done, all their contact doesn't become their perceived support also. So that's another change in the perception, and that's maybe mediating the excessive use of technology. But another thing which comes up is, till now, because of anonymity, the regression is the term which we use in psychology when people undergo various kind of trauma and then they get to that behavior where they feel themselves safe. But internet regression can also come up because of anonymity. You can hold your mobile phone and you can do anything, nobody will know. And because of anonymity, people start accessing, children start browsing XYZ sites, which is not healthy also. And sometimes because of peer pressure and because of their temperament, they start getting into cyber deviant use also. And because cyber deviant use is, nobody is looking at me, nobody can trap me, and nobody can do anything to me. So that's why these reasons become the reasons for regression. So I think internet itself allows various regressive behavior which as a healthy person people will not engage in. So these can also be the reason for excessive use. So what does it leads to? I think some of the terms may be familiar with you, but I think these are all mental health terms. One is called nomophobia. Nomophobia is no mobile fear. How many of us feel comfortable if we are not carrying our mobile phone with us? I think answer is broadly no. I think none of us feel comfortable. And one person has rightly put this term that if I'm not carrying my mobile phone with me, it seems like my my soul is at home, but my body is at workplace. So that much is the attachment has come up. So it means it's a mobile phone, it's an attachment also. Attachment is also another issue in mental health. Maybe I think we are not so attached to the other family members, we are more attached to these devices. But I think all these things require different level of discussions because time constraint I may not go into it. Phantom vibration syndrome is pseudo vibration of our mobile phone. Sometimes you might have experienced the phone is vibrating, you feel that phone is vibrating, but when you check your mobile phone there is no vibration, there is no notification. But it's in your mind that cognitive expectancy that phone is vibrating. And number of time if you check your mobile phone with this expectancy, it again leads to repeated use of technology. Zero inbox syndrome is making the tendency to make your inbox zero. It's any kind of inbox. If your tendency is to read and reply, makes you a repeated user, and that's why there is a syndrome called scrolling syndrome. All of us suffer from the scrolling syndrome. We keep scrolling our mobile phone to find something attractive, and that attractiveness may take 1 hour, 2 hours, 3 hours, or maybe 4 hours also. And that way, it takes away your sleep also. Because if you are scrolling for an attractive thing at 10 p.m., you may find by around 1 a.m. only that something attractive has come. And then 1 to 2 again, see that thing, so again it will disturb your sleep. And then binge watching, we have said selfitis is not a clinical condition till now, but it's a concern because nowadays people are in various risky positions, they take selfie and put themselves at danger. But criteria wise it has come like if you take more than 4 or 5 selfie per day without any specific reason, then you are at risk for, then there may be some other psychological issues which are mediating your 4 or 5 selfie per day. I'm saying again, disclaimer is, if you have occasion, then you can take. But if you are taking without occasion 4 or 5 selfies, and that's why another term which has come is called status psychopathology. All of us have a habit of changing our status quite frequently. And status is a reflection of our mood state. You might have seen that some people who are in a positive mood state, they bring different kind of status. Person who is undergoing different kind of experience, they will bring some different kind. So this is also another expression. For that, again, you need something to be in your mobile phone. Digital amnesia is still not a clinical condition addressed till now, but digital amnesia refers to all of us now have forgot that habit of memory enhancement. Like memory has 3 stages: sensory, short-term, and long-term memory. And sensory to short-term, it goes with attention, and short-term to long-term, it goes with rehearsal. But what happens when any information comes to us, it never goes through these 3 stages. It goes to your mobile phone and one of the folder. And the conditions also comes up The day you lose your mobile phone, how do you feel? We are more concerned about the contacts because we don't know. I think Madam Rita and all, we talk each other, but I think I can't recall her number because I think that's my condition. So, because that aspect and how much this, since we are not using our brain capacity, and that's why people are talking about how much is too much, and whether internet has any impact on brain function, we don't know, because the answer is still unresearched. But people are very much worried because they don't know whom to contact and whom to call, because nothing is there in the long-term memory. We don't know the numbers and all. Doom surfing is another thing, like people are looking for, like during COVID time it has come, that what all can happen to me if I get this XYZ. And that search leads to excessive amounts of internet search to look for, to validate that concerns and all. But last is a positive thing. If you don't have any one of these, but if you are saying that I am using for professional purpose, then you may suffer from digital burnout, because professional purpose also, you are in front of the screen X number of hours. And sometimes digital burnout also refers to webinar fatigue, Zoom fatigue, because 2-3 sessions and then it leads to tiredness of eyes and all. So if long hours of screen use bring tiredness, bring lack of initiativeness, bring exhaustiveness, then it means it is a time to take a break. And that's why we talk about digital hygiene and digital control. But is it all because of technology? It's not. I think it's like there are other thought process also which you use to justify it. Like it's like for alcohol user also who says that I'm productive throughout the day. Nothing wrong if I take 1 unit of drink in the night because I'm not disturbing. And family also doesn't object that he is productive, he is earning, let him enjoy. But that 1 drink every day makes 30 drinks a day in a month, and it makes how many months in a drink in a year. So same thing happens. It can be your negative view of the self. You feel I am not loved. People on online world loves me. They acknowledge me, and that maintain your use. Or it may say I am a failure in the real world. My parents say I am not a good child. My teacher say you are of no hope. And then what is left is internet and social media, where everybody appreciate me and they say I am worthy enough. That feeling of worthiness online world can provide, but we can't in the offline context. That's why I think there is a lot of need for communication. I think I would browse through, otherwise it's not, blaming is not internet, it is a stress in my life. This is your cognitive thoughts to rationalize your use. And they say my parents, school drives me to the internet. And it has been a long day, internet. Sometimes it happens like on weekends, you will find internet use increase more because you feel that next Saturday and Sunday is a holiday. And nowadays you might have seen in the whole world, internet speed slow down in the morning hours. When they looked into the reason, they found it's because of India, because all of us have a habit of sending that good morning things, and so I think we don't write in text messages that good morning and all. We say in text, and that brings a lot on the internet speed and all. So I think all these things are digital hygiene activities which we have to take care of. But what can be the other reasons? I think these are some basic needs. I will not again, time constraints are there. These are 5 Maslow's are basic needs which governs our development. But when we say now people can sacrifice their physiological, people say I don't need food, I don't need sleep, I don't need intimacy, I need internet. So it's internet is because that's why the young couples always struggle that they don't have intimate relationship, because both of them are busy with the social media. So internet has become as important as physiological needs. Safety, people feel I'm better if I'm carrying my mobile phone, good charge, battery and all, I'm better. So again means internet is also contributing to safety need. Then social needs comes where it gives you friendship, it gives you the feeling of worthiness. And the last is self-esteem. People are more concerned about how many likes and other things. When TikTok was banned, one was for people who has a concern that they are losing their profession, because other is they are losing their followership also, because how many followers they will lose. Self-esteem is also, and the last is self-actualization, where people, what I can do. I become a gamer, I become a hacker and other things and all. These are all self-actualized. So if we would not put a conscious control over technology expression of these basic needs, it will become very difficult for us to change it. So it means there are individual, there are devices, there are family reasons for it. So it can be your pathways, broadly if I would say, it can be personality reasons, sometimes because of impulsivity, sometimes because of anxiety, sometimes it could be a coping method, or sometimes it could be a need for affiliation. So this is all what broadly comes up when we talk about internet and mental health. Sometimes these itself can be the comorbid, like internet can be the comorbid reasons for these psychiatric conditions, or sometimes because internet is bringing so much dysfunction in your lifestyle, and because of the dysfunction and you're not receiving approval from others, you develop various mood states and stress related issues. So what we have to do briefly, I think this is simple screening criteria which we have developed. 5C can be answered in yes and no. Craving is, do you have a continuous desire to use technology? Answer can be in yes and no. If yes is there, that's the first yes toward addiction. Second is control. Do you feel that I lose my control whenever I am on the screen? That's a second yes toward addiction. Third is coping. Are you using technology as a method to feel relaxed, as I feel good? If that is there, that's the third yes toward addiction. Fourth is compulsion. Are you becoming compulsive user? So that's the fourth yes. And the last is consequences. Because of that, are you developing consequence in your lifestyle? If all 5C or 4 yes are there in your lifestyle, I think that is the time to take a call to build up a healthy and controlled use of technology. And how you can build up? One generally we advocate is called digital fasting. All of us have to develop some time without technology. Maybe 1 hour, maybe 45 minutes. And that 1 hour, 45 minutes can be used for family time, can be used for your physical activity, and can be used for any XYZ activity where you feel good and you learn to live without mobile phone. And that works well also. Decrease leisure time activities. Increase your digital hygiene. Digital hygiene, when I'm saying every 30 to 40 minutes, if you're using your screen, take a break for 5 minutes. Just blink your eyes 5 times. Move your head forward, backward 5 times. Right, left 5 times. And move your wrist clockwise and anti-clockwise 5 times. 4 steps you have to do. You can, significant extent, you can reduce the physical impact of excessive use of screen. Again, for headphone, most of the adolescents are with the headphones. The recommended advice is every 45 minutes of headphone use, take a break of 15 minutes. If these things come, this build up skills. And even if you want to avoid binge watching, a very hard decision to say, but after each episode, if you take 5-minute break. But I think that 5 minutes doesn't come. So if you can take, it's well and good. And half an hour before sleep time, again very hard to implement, if you can be without mobile phone. If these things parents also brings in their lifestyle, child will follow them. Because sometimes child say, you are treating me, why don't you treat my parents? They are also busy with the technology. So it's mean it's a family problem. So we have to see the whole family. And that's how all activities called digital hygiene. Till now we have talked about sleep hygiene in mental health, but now digital hygiene should also become a part of mental health. And the last is improve your well-being and work on your stressors, work on your other negative coping methods, and feel good. This is another things. We have helpline also, which we run on Fridays, where anybody can call and seek our help, and that we are getting call across India. This link gives all sort of information material which we have developed. Again, it's in the free domain, and we always focus on family into the treatment. And these are some guidelines from pediatricians how to balance your children's use. I think up to 6 years, recommended advice is children should not spend more than 1 hour, and that should be with the parents only. But I think that's very difficult to implement. Child, I think I saw even in the flights and all, I think one child was very much disturbing. The parents gave the mobile phone to the child, and 2-year-old child became settled after having the mobile phone. So I think somewhere we have to see if we can reduce our engagement with the mobile phone. So basically these things comes monitoring, balancing, ensuring, and modeling for the excessive healthy use of technology. So the last always comes 3R approach, recognize signs of digital addiction using that 5C criteria. Repetition of digital fasting, digital hygiene, alternative pleasurable activities, minimize digital leisure activities, and refer or seek treatment if treatment doesn't show any improvement or if there is a persistence of mental health issues. And this is our helpline number and email number for any further information. Thank you. Thank you all. Thank you. So now I will invite, I can invite Ms. Ambika for the. We will have question later or yes. Now or later? No, later. Later, once we have finished.
After Dr. Manoj's presentation, I think speaking about the media and the role of media, when I think about it, automatically, since he spoke that we need detox from technology, so the first thought that comes to my mind is that the media is totally digital now. So for somebody from the media, there is no detox, but there are, of course, as he rightly said, there is something called digital hygiene, and therefore that is something which is very critical, and I'll be talking about that as well. But to begin with, I'll start with a thought, and I'm not using any presentation for a specific reason, because I think journalism is about stories, and as a journalist, if I'm here, I should be talking in the language that I use all day, which is stories. So I will share some anecdotes which I feel is my way of telling what the problem is and how we can probably address those issues. So the first thing that I would like to share, the paintings that you showed, it is not just a painting but a reflection of the circumstances. And it just brought one thought to my mind. There is a place called Underground Unfringed Studio in Delhi, in Okhla industrial areas, many of you might know. And I was there last week, invited by an organization to see an exhibition by children from slums. When I went in there and I started going through the exhibits, it was stories from the lockdown converted into illustrations, something like what you have done in the context of mental health. But after I went through that series, what stirred me was that it was actually a mental health story. Because I'll give you an anecdote. There was a painting, a drawing, where there was a mother and there was a child and a toddler, and there was this girl, and there was a torn 20 rupee note in the drawing. I looked at that story, and then I spoke to that girl later to understand. And I said, why did you choose this, So she said that the common story was that, there was a lot of poverty and there was a lot of anguish in the house and we were not able to afford, and my brother tore the note, so I decided to do this. But the undercurrents were the hurt, the pain, the impact it had on her tender mind. So why I'm sharing this is that as journalists, if we are going out to do stories, what we have to keep in mind is that when we look at any story, we have to look at it in a holistic way. It cannot be an exhibition, it cannot just be a lockdown-related issue. It also is not just a story, it's about looking behind the story for the latent emotion, the fear, the anxiety, all the things that Dr. Manoj just mentioned. They might be clinical diagnosis or a clinical manifestation, but we all experience it through these stories. So one critical point that I would like to make here, since everybody here is a stakeholder and we are talking to each other in a way where we can contribute to build on the narrative. So I think the most important thing is that every story involving the social sector, involving anything that has a social dimension, has a mental health aspect to it. And we as journalists, and we have Kannan sir here, has been looking at these issues for decades. And in the media, I think where we lack and where we need to focus is that just not look at a story in a context like a crime story or a health story or a mental health story, but a story which is looking at these dimensions from the people's problems, the people's perspective. Like the phone phobia that sir mentioned, that that thing about not letting go of the phone. Now, when we're talking about that, I mean, we should be looking at the case studies and bringing those out. So that is one point which I critically feel we need to focus on. The other thing is that today, when we look at media and social media, we as a media are now, there's no difference between print and digital. We are like it's all about convergence. So this is something which people who have been around for 20 years or 30 years in the social sector, in the media, are transitioning to. When I came into journalism, we were largely print driven. So we were used to doing a story in a typical way for a print edition. But now that we are in a digital framework, and when I talk about that, it is social media, which is your Facebook, your Instagram, all other modes, plus the online, which is where the children and the youngsters are. So what you might see in print is actually being accessed by a young person, mostly on the internet. So the language, what we are using, the sensitivity, like there's a lot of criticism about usage of wheelchair bound. Now gradually we have brought in more sensitivity, inclusive language, using diverse ways of saying things differently so that they are sensitive. The queer community, now the whole spectrum that we mentioned too, we use diversity and inclusion in a more, we talk in detail about it. So I think this whole inclusion, because we are now digitally driven and we are more in the face, on the phone, on social media, we can find each other as, this whole thing about people spending so much time on social media. So I, as a journalist, feel that our responsibility is manifold. It's no longer just about being responsible for the story I do for print, but the content I put out on social media, which is whether it's my Twitter handle, whether it's an Instagram handle, whether what I produce for online, what I write for online, so that when the content is out in the public domain, whoever is accessing it is also able to, get sensitized towards these social issues. So this is, I think, a very, very important dimension. I'd like to share an example, maybe that will explain this better. So we do the regular stories, you have an event-based story, you have studies, you have data, you talk to psychologists, psychiatrists, those kind of stories. We all are reading about the trends. But we tried to do something differently at TOI a few years back, because maybe this is a dimension Dr. Manoj may have looked at. When you are sharing a story in a clinical setting, a doctor is very ready to absorb and assimilate those emotions. But when a journalist is coming face to face with a survivor, and I'm talking of survivors because, again, when you're talking of digital detox, digital addiction, you're talking of the range of emotions, you're also looking at that every survivor is coming with some mental health concerns. It may not be clinical, but the manifestations can be anxiety, can be a whole range of things. So we were realizing that while we were reporting a story, maybe just taking a paragraph or a quote out of that entire story, we were leaving a lot more unaddressed. Whether it was from the reporter's perspective, because I'm carrying so much within me, but I don't know how to say it because I don't have that space. Similarly, the person who's spoken to me has spoken with a lot of hope, with a lot of anticipation that, let me say it all. Maybe, I'll find my solution here. So we did something called, and it was sort of an experiment, you may call it. We decided to launch a series called Predators Around Us. This we did at the Times of India in 2018. I can share the links later, Rita ji, maybe, if somebody would like to look at that. So what we did was that instead of going to survivors, we decided to go to common people like you, me, all of us sitting here, and ask them if they know anyone who wants to break their silence. And we will provide them that space where they can talk anonymously, because that's what mostly whoever came on board, we also gave them the option to go if they wanted to speak up as and who they were. And we would say it in their words. We would write their stories in their words. It took us 6 months. Why I'm saying this is that how difficult it is for people when you are not in a clinical or a setting of an NGO to actually come out and speak to the media. And that was a revelation for us and a learning. Why? And since we are also talking to stakeholders within the media from here, that, you know, when I come to Dr. Manoj or to Rita ji, I will get to speak to survivors. But in a room full of people, people will not want to come to me till we create that trust, till we create that space that, okay, I'm here listening to you. So in 6 months, we got about 5 voices. And these were not through NGOs. They were individuals who spoke to individuals, who spoke to individuals. And we had people, including 2 men, who came up. And these were all people who had faced child sexual abuse, rape, violence in their homes, and had not been able to report. And we told them, when they reached out to us, we have the WHO guidelines, we have a lot of guidelines which also make us responsible that when, you know, somebody has not shared something with anyone and they are willing to share with you, you have to comply with those guidelines, connect them to people who will be able to help them after the sharing. So taking all that into account, we gave them the time. And it was unbelievable. When they started to share, they were not speaking to me. They were speaking to a space that was their own. You know, I can't explain that feeling. Maybe Dr. Manoj or Kannan or others may understand it, but being from the sector. But it was, I couldn't believe that somebody could talk about intimate details with such detailing to a person they don't know, but they are trusting because you're giving them anonymity, giving them that opportunity to speak up. So we did that, and we did 5 stories, Dr. Manoj, and you won't believe it. After that, we were flooded with people who wanted to come and speak to us. So what we did, we obviously couldn't do everybody because naturally there are case details and we can't look at children and we cannot look at those cases. So we referred them. And we created a box in that story, that digital story, where we said, these are the places where you can go and seek help. You can come to us, we can take you to these places. And we profiled 5 people who came to us just because of that series. So I'm just concluding. Why I'm saying this is that as media, we need to create these spaces. That series eventually, we realized that we need to create a platform. So we put it on a specific platform where people can access it at any point of time, see it, and probably come back to us or seek help. So this was one example I wanted to share on how we can create that interface with the media and the concerned, the survivors, and create a situation where there is sensitivity and there is safety. So thank you so much. Yeah.
Presentation of information as well as also improving the mental health of the people who receive those information, because now a lot of concerns are coming up that people, or it's not adolescents or adults also, it's a lot of things from the media because they get exposed to it a number of times, sometimes because of curiosity and other things they get into those activities now as a person who become a victim or as a perpetrator also. So definitely there is a need for holistic presentation of media. Thank you. Now I invite
First of all, I would like to thank the organizers for inviting me to this conference and organizing a conference on this very important topic. I think a broad-based discussion on mental health involving everyone in society is the need of the hour, and you have taken the right step in organizing this. Dr. Manoj and Ambika ji have already set the context and shared a lot of things, so there is actually nothing left for me to say. But I wanted to begin with some personal stories, because mental health is actually touching everyone. I mean, all of our lives. And Dr. Manoj, I have incidents in my close circle, which exactly describe your first case study that you talked about. And this is a case where I am personally involved, and many times we feel that, when we are trying to tackle this, the school passes on the buck to the family. The counselor, gives some advice, and then, they say, it's up to the family. And in fact, 3 days back, they tried to, the case is the same, so I'm not repeating it. They tried to, the counselor said, internet band kar do unko. तो इंटरनेट बंद कर दिया, लैपटॉप छीन लिया, और इतना बड़ा वायलेंट हो गया बच्चा, और उसने क्या अपना मोबाइल फोन नहीं तोड़ा, अपने मदर का मोबाइल फोन तोड़ दिया उसने. And we are at a loss, this, is my brother basically, it's my brother's son, and he spoke to me, he was narrating the entire incident to me, the complete loss, what to advise to him. Just 14 years old, and what you have described is happening, more than 5 to 8 hours on the gaming, not going to school regularly, academic dysfunction, slowly he's losing on his academic, he's in class 10th now, and we are all worried. And the most important point here, what I felt was, instead of the counselor, the school, and the parents working together, they're just passing on the buck to each other. And that is something that, probably I will seek advice from you offline, but that was my first story that I wanted to share. The second, I come back to a 19-year-old boy, and he is good with information. He is having psychosis, but he is able to actually surf the internet and take information that's useful to him. And he himself, takes, he's in Bangalore, he's studying Christchurch University, and he, the parents are facilitating, but he talks to the psychologist and the therapist himself. So this is a positive use of how he's using the internet to cope up with anxiety and stress. And the third one is of health anxiety. And here, you have given me the term to describe that case study again. You said doom surfing, right? Confirming. He thinks that he has cancer. And every time, he goes to the internet, he relates it to his symptoms, and then he says that, he has cancer. He confirms the diagnosis that he is having. So all these three stories, I'm sure all of you have stories in your own, home or neighborhood where these kinds of incidents are happening, and it's a catch-22 situation. These are increasing incidents of psychosis and neurosis, but we are not able to do anything. So thank you very much. I can cut short on these three case studies because you already described them very well. But the important thing here is, in all these cases, because I've been personally involved, there is a sense of helplessness on our part as well in terms of what to do. And that is where one feels that, for example, a simple thing like, a mental health counselor visiting home. We found that very few services are there, and those services are also, are at a premium, basically. So, there are a lot of things like this. But the most important thing I feel is, this is a case of a 14-year-old, a 19-year-old, and a 24-year-old. And each one is having some problems with the internet. Problems in self-regulation, problems in, easy access to information and all. But the context in which, the families are there and the context in which the children are growing up, they matter a lot, as you have said very well. So I was, before coming here, I was looking at any guidelines that exist. And in fact, today the American Psychological Association has released guidelines on health advisory for, and what they mentioned, and that's what was there in my mind as well, that the technology space, the social media space is by itself neutral. It's neither positive nor negative. It's the way you are interacting with it, and the interaction happens in the context of your development, your growth, and the circumstances in which you are there. So it's a holistic approach that we need to take when it comes to tackling these issues. So from my experience, I mean, I have worked in both the media as well as the development sector, and we have had interventions, where we have looked at how we can use media and critical thinking to actually help people cope up with negative situations. And we have also done some experiments in the area of mental health. So one thing that I feel that's very, very important is to promote critical thinking. That is one thing that happens very less. I mean, education has become very rote and monotonous. And in terms of critical thinking, what we did was, in the context of health information, when I was at the George Institute, we launched a program based on evidence-based approach to critical reading of research papers, which was started by Oxford. And we brought it to the media sector. See, all of us are consumers of information. Then how do you actually then use those information in a way that is useful to you rather than harmful to you? So these people, what they did was, in the context of reading research papers, they developed checklists, very simple checklists, which we adapted to media, and the same thing could be adapted to social media as well. I mean, it's very simple, that 10-point checklist, like, is the information really new? Is it relevant? I mean, what are the harms of this information? What are the gains of this information? And is there science supporting the information? Most of the health-related information, if you ask this question, if there is evidence supporting the information. I mean, when I Google things, I automatically go to, use keywords where, you try to get evidence-based information rather than simple information. Internet is full of information, misinformation. But if you are able to actually, look at the science behind everything, so one of the questions is there science behind this intervention? So the usefulness, the appropriateness. So the entire critical appraisal program is based on three, important areas. The validity. I mean, in their case, it was the validity of the question, the authenticity of the method, and relevance of the results. But what we adapted the same to the validity of, let's say, the story, the media story. How valid is the media story? Or how valid is the information that's coming to you? I mean, many times, the same old information is recycled and presented. So the validity of the information. Then the authenticity, who is giving the information? Where is it coming from? The source. I mean, people don't check the source. In WhatsApp, there's a lot of things in circulation, and the source is very, very important. So the validity, authenticity, and finally the relevance. I mean, we can find information about something being used in some other context, in some other geography. Is the same relevant here? So what we did was, we adapted this media literacy program, critical appraisal skills, to health information. And then slowly we started expanding it to mental health. I mean, in the area of mental health, we just added two more questions here. One is, of course, a question related to the copycat mechanism. I mean, especially it was a checklist on suicides, and the second one was on the science supporting it. So the critical appraisal program, or critical thinking training for students at a very early age, is very, very important, and that is something that I feel is needed and that is missing. So that is one. In terms of social media, I mean, I'm sure you have heard of the trainings being offered by Health Analytics Asia. Social media literacy, the technology backend, how the technology backend is being manipulated to present certain information. I mean, or let's say, to ensure that certain information pops up before you, and certain information doesn't pop up. How search engines are being used to optimize certain kind of information. These are the kind of things that one can actually learn and become a little more literate in terms of how technology is being used to present information in a partisan way. And once you start learning, I am not very savvy here, but once there are organizations offering this kind of technology end of the media literacy. So when it comes to social media literacy, there are two parts. One is the overall media literacy part, where you understand that media is just the representation of reality and not the reality per se, and the second is the technology end. So I think critical appraisal of information and media literacy go hand in hand, and if both are done together, and the intervention needs to start in schools. The third thing in which we have done a lot of experiments in development sector, and it can be really very useful when it comes to mental health is participatory media. I was part of a campaign called the Cyber Salamat campaign, which was started by World Comics India. World Comics India is an organization which uses participatory comics as a methodology to actually sensitize and also involve them as co-creators of a media. Okay, so these are wall poster comics in 4 panels. And so what we did was, this was supported by the, forgetting the organization's name, Omedia Network, it's called the Cyber Salamat campaign. If you Google Cyber Salamat, you'll get a lot of information about this. So basically we involved, rural young women and men and young people to actually talk about issues from the internet that is plaguing them. So My Mobile Story was the name of the program. And they mentioned about a lot of things which is going on, in terms of the mobile. Simple thing like, how you navigate banking, how you navigate, the information, the emails, phishing, introducing these concepts like phishing, then internet fraud, things like that, and then asking them their experiences, and then they draw those experiences in the form of stories. So this was something which is very, very useful, and generally I have found that participatory media methodology is a very powerful tool in terms of involving. In the field of mental health, I know theatre has been used in a big way. But same, grassroots comics or puppetry and other things can be used in a very, very big way. I am a big votary of participatory communication. So participatory communications, especially comics, can be used in a very powerful way to involve the internet users, the children and adolescents, in a positive and meaningful way. The fourth thing which currently I am exploring and which I find is very, very helpful is a little offbeat from the track of this conference, but then I was Googling about, I was researching about its evidence, and that is the role of wisdom traditions in promoting mental health. And I find that there's a lot of literature in terms of how the wisdom traditions have been used positively to promote mental health. Sans religion, the secular texts, which talk of, coping, resilience and all those things. But at the same time, the religious texts themselves, So there's a lot of information. And I was looking at, some experiments done in Western countries using our traditions. Like Michael A. Singer has written a book called The Surrender Experiment. And the surrender experiment is all about giving you likes and dislikes, and going with the flow of nature. He gave his life to this concept. And then he has written this, beautiful book called The Surrender Experiment. And I find that, when going back to, the Bhagavad Gita or Quran, the Bible, it all talks of, likes and dislikes and how you need to actually control them. Secondly, when you look at, I'm just mentioning 3 or 4 things here. When you look at Brené Brown's concept of vulnerability, and Brené Brown is a sociologist, and she has explored guilt, shame, and vulnerability. I'm sure you know, sir. But what I find is, all these things, have a mirror in terms of, some of the wisdom traditions which are saying the same thing. I don't want to go into the details into this, but Brené Brown's concept of shame, vulnerability is very, very interesting in terms of, accepting your condition and being who you are. Similarly, I don't know whether you are aware of this book called The My Stroke of Insight, where, this lady talks of, she had a stroke, she was a brain scientist herself, her name is, I think, John Taylor, and as she has her brain was shutting down, one part of her brain was shutting down, she became an observer to her brain function shutting down one by one. And what she found was, as her left brain shut down and her cognitive functions went down one by one, her right brain was one with the universe at the same time. And there she was able to describe the difference between the right brain and the left brain, and how, the right brain carries the seed of entire existence within yourself. Again, I'm not going into more details on this, but these are very interesting things, which, experiences that one can read. And then, a lot of school training she's doing in schools in terms of, how to use your right brain. So just I'm finishing. How you use your right brain. And that is what I find missing. So finally what I would like to say is, if you can look at Daniel Kahneman's, the thinking fast, slow, and in our media literacy program we use a lot. We are all used to thinking in the autopilot mode, doing things in the autopilot mode. But if we are able to actually slow down and think and reflect, then I think, much of these problems can be solved. So it's very good that you are thinking very holistically in terms of this, and that is where, I think the media, wisdom traditions, everything matter. Thank you very much.
Thank you, Mr. Kanandi, for an interesting presentation. And again, the concept of holisticness has come in the presentation. And Mr. Kanandi also brought out the critical concept of critical thinking, which definitely required to be a question about the pros and cons of using the technology. Second is social literacy, which also complements critical thinking. And the last is wisdom traditions. And all these different things can become a milestone for healthy use of social media as well as healthy modality for mental health issues. Thank you. So now next.
Sorry. Good afternoon, everyone. Firstly, thank you, Rita. Thank you, Butterflies, for inviting Rati's work onto this platform. And I just want to say what a great pleasure it is to share a platform with Dr. Manoj all over again. Since I am clearly that preliminary sort of diagnosis has happened, right? I'm clearly an excessive user of mobile phones, and another sort of great pleasure to share the stage with Ambika, who's really one of the most sensitive journalists, has taken some of the issues that we worked with, and a pleasure to meet Mr. Krishnan sir as well. Yeah, so hi, I'm from Rati. We are based in Mumbai. We run, is that the first slide? Is there one before this? Yes, sorry. Yeah, you can go on to the second slide, yes. Next slide, please. Oh, sorry, do I shift it from here? Got it. Oops. Yeah, hi. So basically we run a helpline based in Bombay. It's for children facing, we started off as a helpline for children facing online risks. If there is any child who faces an online risk, all they have to do is they can either dial in to 6363176363. Yeah, they can even WhatsApp, right? Children prefer WhatsApp more than calling in. Number one, nobody can sort of hear them. There's much more sort of privacy when they type, etc. And we launched it just about, let's say, about 7 months ago, right? So for the rest of this session, I'm just going to present data of the calls that came in. So these are issues that children had. I'm not going to go into specific case studies. If you want to know them, I'll talk about it later. I'll give you the mota data, right? So as now, I think we've already established kids are going online, kids are indulging in risky behavior, and kids are facing the impact of it, right? And I think what this is an intervention that we've put in place as to what can be a potential sort of holistic response, So it is very casework oriented. It is core social work, but we've put in the aspect of technology. So like I said, it's about 7 months down. I'm holding it ulta, sorry guys. So we have received a total of around 650 calls Yeah, so these include everything from inquiry calls, calls that are not relevant, etc. Right? Anybody who's had a helpline knows that about like 90% of the calls are not really cases. Now, how many cases have we got? 30% of the calls that came in are cases. That means that they were issues that we had to work on in a case intervention manner. Yeah. Where did we get the calls from? We got the calls from 22 states and 2 union territories. Okay, the states from which we got the maximum number of calls, and they also tie in very closely with the NCRB data, which is the national crime data. So maximum calls were from Uttar Pradesh, followed by Maharashtra, followed by Karnataka, Delhi, and West Bengal. Yeah. Age of the victims. Like I said, when we launched for only those children who are below 18. But what we realized is that now because of the lockdown, right, a lot of children had relationships in which, like, the other person was remote, right? Now at that time, maybe the child was 17, right? And then like the lockdown opened, these guys met, now there is a friction in the relationship. So the image that was captured and taken and now is being used for blackmail, in that the individual is a child. Right, so we sort of started getting cases in which the content was taken when this person was a child, but now this case is an adult, right? So what we realized, and again now for here we again went back to, right, what is the basic risk-taking age, right? So the risk-taking age will be, as mentioned in today morning, like from adolescents all the way up to 25. And that's where we are also getting the maximum number of cases from. So 84% of the cases are from the ages of 15 to 25. Yeah, so they go online, they get into trouble, and then they sort of reached out to us. But the youngest victim who called our number was 12, and the oldest person who called our number was 49. Yeah, victims. Largely, the victims identified themselves as women. 22% of the victims were male, and 1% identified themselves as non-binary. Right, and now what were the issues reported, right? Now, the majority of the issues that were reported, right, and this is like, the just broader sort of definition, was cyberbullying, right? So you can see it's clearly like, about like, of all the cases that we've got, about 200 instances of just sort of cyberbullying, right? And cyberbullying, of course, like, the severity varies. Sometimes it's just like, oh, I don't like your face, right? But sometimes it's about as serious as like, I have this like photograph of yours in which you are sort of, it's an intimate photograph, and I'm going to release it if you don't do this. So, so the severity in these cases are all over the spectrum. Then about, let's say about 50 odd cases of loss of intimate content, right? Which is like you had a private photograph of you and it's going to be leaked online, right? So that was the second most concern. Then kids sort of calling in and reporting mental health concerns. That was the third most sort of like, call we've received. And about a little bit of calls we've received did not have any sort of sexual element. They were all about on-ground sexual offenses. So these were like on-ground POXO cases. Yeah. Yeah. Now, just to sort of divide and, so this will give you an exact idea of what happens, to children online when they face risks. Okay. So I'm not saying danger, but these are the risks. Okay. So 31% of the cases were about impersonation, which is someone takes your photo, makes another account, adds your friends, and then sort of like uses it to sort of, what can you say, spread rumors about you, defame you, etc. So this is the maximum number of cases that come to us. Other than that, what we have is threat of online consequences. So see, the stereotype of the case that comes to us is that there are two people in a relationship. The intimate content is passed. When you're in a relationship, the relationship sort of develops a friction. One person says that I'm going to leak this content. That is the stereotype of every case that comes to us. So about 18% of the cases are about that. Cyber stalking, so basically following someone around, basically like crazy cases, right? Like somebody knows that you're online, they will take a photograph of you marked online, send it back to you. So just stalking you, telling that every time you come online, I know that you're online. Sorry. And then, of course, like, cases of grooming, harassment to say non-sexual content, etc. Yeah. And this is regarding like, sexual content, which is like intimate content. So in most of these cases, what was there in the intimate content is solo sexual activity. Yeah. So in India, I think there is a fear, or at least in the cases that come to us, there is a fear that I am not going to send you a photograph because I know that it will be stored in your PC and you will use it against me, right? So then what is negotiated is a video call, right? Ki I will do a video call, so we don't have any permanent proof, that this is something that's going to, it's just a temporary thing. But what happens during the video call is people sort of take screenshots. That is the most common form of case of intimate content that comes to us. So children are putting in some barriers, right? Children are aware that there is a danger, they take an informed risk, and sometimes it backfires. Other than that, of course, like India is known as the sextortion capital of the world, right? Everybody, even adults, face a lot of sextortion. So the cases of sextortion are even now, just now we are getting a lot of cases of sextortion in which children are involved, right? And with children, it won't be jobs, it will be education loans, Like I'm going to give you an education loan. Can you send me a picture of your body? Because, this is part of a physical examination. So this is a grooming technique that was used, and this is of course for children because it's education loans, etc. And then of course erotic posing, partial nudity, etc. Yeah. The top 5 sort of reported apps in which this happens. Instagram, obviously, because most children are on Instagram. We also advertise heavily on Instagram. So the incidents that we get are largely on Instagram. WhatsApp, the most commonly used app in India. In the research that we did, it's the most commonly used app by children in India. It's also a secure app, so it also does not have a report function. So it does not have a very powerful, very prominent report function. So perpetrators are also more confident on it. Then of course Facebook, Snapchat, we're getting a lot of cases, and of course YouTube. Now, so actually when the cases come, it's sort of easy, when it's on these platforms, because there is some way you can take some sort of action, right? Now what happens is that TikTok is banned, right? Now children in India are still using VPNs and doing TikTok account. Okay. Now suppose there is a problem on TikTok, who do I go to? Right, there is no India office. Similarly, PUBG, similarly all these banned Chinese apps, these are banned in India, but children are downloading modified apps and using it, and when things occur there, then it becomes very difficult to intervene. So this is a question for you guys. At what point, right? So this is like the caller on the internet. The caller is safe, now the caller is experiencing some risk, and then the caller has fallen in danger. At what point do you think callers are reaching out to our helpline? Huh? Yeah, correct. Yeah, good. So everyone's a good case worker. So when absolutely everything has gone wrong is when children reach out to us. We get a few calls preventive. Ki maine usko photo bhej diya hai. Sorry, I have sent him the photo. Now I'm worried. Those are terrific cases. You can put in some safeguards, right? But 99% of the cases have come to us after the leak has happened. Yeah, after the situation has become extremely critical. So what do we offer them? We offer them around 4 major kinds of support. So one of the major things that we offer that is very difficult is technical support, which is we offer content takedown. If your content is there, you're worried about that content, we will help you as much as possible in content takedown, and we will also help you to prevent re-upload. Yeah. So in the last 7 months, we have taken down 184 reported accounts. Yeah. So these were content that was breaching this, sort of uploaded, and it was going viral, or it was being used to harass, and we managed to take it down. The other important aspect is counseling support. So basically the way we see mental health at the helpline is that content takedown and the mental health support, they go hand in hand, right? So when the content is still live, there is a lot of panic. I mean, I'm not a social work expert, so when people are sad, I say depressed ho gaya, which is completely wrong. But it's a layman's language, right? So when the call comes, the content is still online. There is a lot of panic, anxiety. They even they shout on our counselors, ki abhi tak ye kyun nahi nikla? Why isn't this coming down, right? And then our counselor works with them, So while we are processing the content takedown request, our counselor works with them, and these 2 things go hand in hand, And then when the content takes down, 90% of our clients no longer need mental health support. So content being up there as far as I am concerned, based on like my experience and our experience at the trust line, content being up there creates this like, enormous mental pressure and emotional pressure on the child, So they just drop out, So some of our counselors who were trained counselors who worked with iCall and all that, they came back and they're like, I'm not getting a chance to do long-term intervention, So that was a problem that because kids were just immediately dropping out once the content was gone. They're like, I'm fine. Thank you for your help. So that's something that is an observation. Then we also give legal guidance and support, right? So this is a very new thing, right? Like, what happens when you go to the police station to report, somebody sort of messing with your social media account, right? So if it is very serious, do you know that the police will confiscate your phone, right? Now imagine from a lower socio-economic family where the perpetrator sent nude photos to the entire family, right? The entire family's phones were confiscated on one day. So just imagine, so we are not aware of all of this because very few cases are actually going through the criminal justice system. So why we give legal representation is we'll also learn what happens when these case enters and we can then inform our families. But one good news we learned is that if the perpetrator has had photos on his phone and threatened to leak them, the judge denies him bail. This has happened in a lot of cases. So we are just learning about this system because the issue is also new. And of course, social support, right? It's just like any act of abuse. There are it's not just one vulnerability, ki mera content is online. It's mental health vulnerabilities, it's social vulnerabilities, all the stigma that you associate with a child sexual abuse case will also apply. So we offer them social support as well. So in 17 cases, we offered on-ground support. So what are some of the patterns, right? So children in love, right? It's such a dangerous word to say in India because of the whole legal thing, but it's very clear children are getting into relationships, children are exchanging intimate photographs, right? And children who are in love are extremely at risk, okay? So one of the main to-do things for all those who are working with boys is that how to handle a breakup. I think, that needs to come in like training sessions at a community level कि जब आप breakup करते हो तो उसका वो लड़की का photo delete करो, block, like it has to be in a module format. I'm not kidding. It's huge. Most of the perpetrators are male. And it's sad, because the case comes to us and the women counselors are very angry and the guy counselors are like, oh dude, what is he doing? Why is he doing this? So it's a very we have a gendered reaction to this in office. Male perpetrators, abuser controls the data, right? So the boy, what does he know? Ladki's mother, the girl's mother's number, the girl's father's number, the girl's uncle's number, okay? And I am going to send your photo to everyone, okay? He can do that. Girl, okay, I know he lives in Gwalior, but I don't know where exactly. Right? So this is what we, people, when the whole Aadhaar discussion said, people were saying, data doesn't make you powerful. What is data? I can give my data. But here in these abuse cases, you can clearly see how the asymmetry of data is making one party very, very powerful. So it's the person who has the more data exercises more control in a situation of abuse. And then targeted abuse. So one of the worries that we have is that my photo will be leaked anywhere on the internet. Okay, so I think I'm a little less scared of that scenario now since I've started doing active casework, right? Because internet has pornography, like in the last half an hour, like terabytes and gigabytes of pornography have been uploaded. Nobody cares, right? Maybe you'll see it, maybe you won't. But the way the perpetrator operates is I am going to send it to someone right? So it's very targeted, very specific sort of abuse. That is the pattern that's emerging and not like an info dump or like a data dump that we once feared. Mental health, I think I've spoken about most of them, they're dropping off. And another part of where mental health becomes sort of issues is that the child is isolated from the parents. The child is the only person who knows about the case in most of the cases when they reach out to us, right? So that negotiation of can you reveal it to someone in your family? We'll also speak to your parents. That's also an intervention that we provide, That becomes very tough, where the child starts losing faith in us. The child is very happy. Okay, I'm going to report it on Instagram. I'm going to report it on cybercrime.gov. Very happy. I'm going to tell your parents. It becomes again a very huge situation and the graphs go up and down. And self-generated content, I think I've already spoken about. So basically, I think one of the briefs that were given to us is what should children do, right? So I think one of the things is we need to tell them to yes, of course, we always say block him. Okay, we always say block him, but like if the case goes serious, don't before block him, take screenshots. You know, like he has data on you, you need to have data on them. You know, like there have been cases where when the girl has said, "See, I have taken a screenshot of this message. If you don't stop this, I'm walking to the police station." That dhamki, because now the girl has data, na? That has been enough to shut down the abuse if it's a peer, and in most cases the abuser is a peer. Then. Hide your contacts from perpetrators. If you meet someone online, don't share like, you know, ye mera mummy ka number. Like there's a tendency because in most of the community and a lot of communities that we work with, there are shared mobiles. So one day I'm calling my boyfriend from my brother's mobile. Next day I'm calling my boyfriend from my mother's mobile. Next day I'm calling a boyfriend from my father's mobile. Now what happens? That guy has the mobile number of my mother, brother and father. Right? So this is a shared device ka risk. Extortion cases never pay money. It's a volumes business. If you don't pay money, they will move on to the next victim. Immediately report. India, under the new IT Act, has something called grievance officers. If you search for it, it will come up online. If you are also facing an issue, you can write to grievance officers. So, see, 30% of the things we do at the trust line are specialized, and we have developed partnerships and technology for it. 70% of what we do is available to any person. You know, one of which is the grievance officer function. So it's something that, like, if you're working on cases, doing casework, it's time to upgrade your skills and learn, you know, because abuse is not just offline, it's also online. Then, of course, telling a trusted adult, going to a police helps. It's tough. It's very tough. The police are very not sensitive. Again, we need to resensitize the police, you know, because so the online issue is very different from the on-ground issue. And then, like, there are mechanisms like cybercrime.gov, Childline, stop NCI and take it down. If you have images that the perpetrator is linking, you can upload it onto these platforms and they can help to a certain degree prevent re-upload, you know. That's the new technology that's come in. And see, one of the, like the last thing I want to say is that like we are also doing a research of children in marginalized communities and how they understand and interact on the internet. So the cases we are getting on the trust line, like Mr. Manoj said, is excessive usage, problematic usage, porn addiction, you know, like I went to this dark web pe maine ye dekha, now I am traumatized. Okay, but the children that we are seeing, they have missed their online classes. They have not even had like 1 hour of phone. Girls are not able to access internet without like the elder brother looking down and peering into the girl's mobile. So, you know, because this is Delhi and Delhi is very close to policy. So when we are suggesting policy, we have to realize in India, if this is true, then the opposite is also true. The pandemic has created a huge digital divide. You know, so children, 90% of the children have internet access, but do they have meaningful access? Very few. You know, so do children have like, you know, meaningful you know, so when we talk about a lot of case studies here, it's a lot about children who have meaningful access. But if you see, it's just 43% of India who's connected to the internet, right? I'm winding. You know, so and it's again like, you know, huge divide between urban and rural. So whenever we speak policy, it's important to look at like both the haves and the have-nots, and something in policy to bridge these both as well. You know, so it's not true that all kids are constantly online. There are kids who are yet to be connected. You know, people say na ki digital migrants, digital natives. India is still digitally migrating at a very, very slow pace, you know. It's not as meaningful as one expects, because the children around us are very different from like, you know, what happens when you're in Bombay, when you enter Govandi. Yeah, so this is the research. One copy of the research, the first part of the research I've left outside, so please do it. This is our number, this is my email. You know, so yeah, thank you very much.
Thank you so much for interesting work and all the best for your work. And do we have time for questions? Or I think we can take few questions. The organizer says so. Yes.
I primarily actually have questions to Siddharth about the helplines that we cover. So my name is Shivangi. I work as a social worker with children who have been sexually abused. So you mentioned about the phones being confiscated. Yeah. You mentioned about the phones being confiscated of the children, right? Is there any way you've been able to figure out how to get those back? Because that's one thing we struggle with a lot.
No, like,
No,
you know,
right?
so it's very difficult. Like,
Yeah.
when by the time they come back, they're not viable phones
They're
anymore.
not viable phones,
Yes.
right? So there's no actual.
No, it should, like, you know, it's the entire, see, once it enters the police station, it takes
then
its
nothing
time.
can be
So
done.
it's like,
I just wanted to check in case
Yeah.
you have been able to figure something out.
no, so it's like when you lose your purse and if it goes for evidence, then,
Right.
you know, like by the time you come back, it's not a purse
Okay.
anymore.
Also, the kind of support that you provide, how do you tackle mandatory reporting in context of children who are in love?
Yes.
Particularly.
So, see, basically, there's a great thing called cybercrime.gov.in, right? So, with every case, you know, we tell our children, those who are below 18, those who are above 18, it doesn't apply. Those who are below 18, we will have to report, okay? Now, on cybercrime.gov.in, there is a report anonymously function. So, all of our cases are reported anonymously. Where the child gives us consent to give further details, we provide that. At the count. Yeah, anonymously means we'll give our number. We'll report from our number. So if you go on cybercrime.gov, I think, you know, once you go on it, you will see. So there are two ways of responding. So one is where you can track the case. So in which, like, you know, if the case is in Bombay, we are doing the something. So we will, like, you know, do track a case because we are there. So, you know, if there is any consequence to the child or if there is any interface with the police station, our social workers are there. Now, if it is further, when you report anonymously, you don't have to give any details for the child. You can give all the details for the perpetrator. So when you... Who is also the child, yeah. Yeah, I know that. Yes, no problem.
Sir, this is Dr. Manoj Kumar Sharma, sir. I heard about the shut clinics. In the context of the corona pandemic, is there any drastic shift in the dependency of the internet addiction as far as the children's and the adolescent age group is concerned? That is one question. Secondly, by going by your vast experience in the last 8 or 10 years about the internet addictions, are there any policy issues which you can suggest or you have already been submitted to the IT ministry that how this menace can be taken care? Because as you know that this internet addiction is not only related to the child or adolescents or to the particularly to the students group, but across all the age groups there is addiction has been gone on, and then so was the cybercrime and other issues. So from your experience and because NIMHANS is a center for Institute of National Importance, so a lot of weightage and your listening has been given to the ministry. So in that way, what are your feedbacks? Just wanted to know from that point of view. Thank you, sir.
And I think because of pandemic, what has come is the increased use of technology across our age group. So that's why I think if you go with the core definition of addiction, it is less than 5% only. So not all people who have excessive use will meet the criteria for addiction also. But majority of them, like 75 to 80% of the people meet the criteria for problematic use. And where I think most of the people fall. And these are the group who can do very good with if they get support, if they get psychoeducation, if they get further skill-based things to control their technology use. Because sometimes what happens, family become judgmental. If the child touches the mobile thrice in a day, 4 times in a day, parents start labeling that he is going to become addict. If they are going to receive this word addicted 4 or 5 times in a day, there is nothing wrong. If everybody feels me addict, I can continue with my technology use. So definitely all stakeholders require to reduce this problematic, which is a big number. Second thing which comes up is in terms of recommendation. Both Minister of Child and Women Empowerment, they have brought out guidelines for healthy use of technology. NCRT also has brought out guidelines for healthy use of technology. The main mechanism always still remains is building up awareness, give information so that they can take a call for healthy use of technology. And regarding law, still we feel it's a public health issue, so all stakeholders should participate to promote healthy use of technology. But recently, Minister of Electronics and Information Technology in recommendation has brought out that even children and adolescents who earn through gaming, whatever the earning comes will be taxable.
And otherwise, rest is public health issues. But I think still I would say the main reason for excessive use is fear of missing out something. That you don't want to miss out something, because sometimes child says, my parents allow me to log out by 10 p.m. but my parents remain active till 12 or 1 a.m. So kindly allow me to use mobile phone till 1 a.m. so that I will not become odd man out. Same thing happened for adults also. But now the time has come that instead of mode, we have to encourage joy of missing out something. I think all of us should build up this thing in our lives. Thank you.
Sir, here. I think my question goes to the same sense. We are in the word. Sorry, my name is Shasta. I'm from Rwanda. My question goes to the same orientation. We are in the world that is really moving to technology. You get abused digitally. You are supported digitally. I don't know how Rita managed to get this face-to-face conference, but now it's just a webinar, Zoom conference, it's online classes, it's online shopping. So we are moving to this digital technology, and I think we are approaching now, we already started to this artificial intelligence. All things will be done by technology. I would like to hear from, I don't know who I am asking, but your position. It's not only on children and adolescents, for all of us. About this use really of technology moving from natural things to digital and the technology. That really any reflection position.
I would request both Ms. Ambika and Mr. Kanan to speak about this issue.
I mean, you want to know our position?
Perspective.
Yes. I think technology by itself is not bad. It's how you interface with technology. These days everything has moved to technology. I mean, one part is you can't remain with the mobile phone. Second part is all banking functions, all essential communication. Everything has moved to mobile phone. I mean, gone are the days when for paying electricity bills or a water bill, you used to crowd the centers and stand in queues. I stood in queues 20 years back. But these days it's just paying a click of a button. You don't go to the bank to actually withdraw or transfer cash. I mean, nobody withdraws. Very few people withdraw. I mean, so a lot of functions, normal functions, routine functions were like a move to, the internet. And there's a technology backend there. So on the one hand, it's like technology is like the Frankenstein monster. It is a double-edged sword. On the one hand, you get a lot of useful information. I think that is what I feel that it's not about you are a consumer of the information. Be an intelligent consumer. And how do I become an intelligent consumer? That is what we need to get.
So I also feel the same, that technology is very critical. I mean, you need it today. It has the entire pandemic. A lot of people managed to get through those situations because we had online platforms. We were, as you yourself said, that she's managed to get everybody together in this room, and earlier there were Zoom meetings. So there is a flip side and there is a positive side as well. So how you use technology is what matters, and that's where Dr. Manoj had very nicely explained that we need to draw the line. We need to know how much is dangerous, how much is good for us, how much we need to get into it. So that's where I think, the whole summing up happens, that we need to, as media, since I'm from the media, I can say that that's the role that we need to play, build awareness about it, that how much is good and how much of it we need to use and where we need to stop. So that's...
just, this question reminded me of like when we were building the helpline, we asked the kids, okay, how do you want it? Okay, and one of the biggest answers they said it should be answered by a real person and not a bot. So, just to offer a counterpoint as to like how children perceive, So they didn't want a bot, they didn't want technology, they wanted a real person at the end of it. So.
Hello, sir. Okay. Can I ask just a question? Hi, my name is Kavita and I'm working in Hug Center for Child Rights and have been heading a team of social workers and counselors who are victims of who provide psychosocial support to victims of sexual abuse. So my question to Manoj sir, to you, when you were doing this research on addiction, did you come across cases where children very increasingly post sad messages on WhatsApp or on other social media, which is a very it's a new term which has come up, sad phishing. So what is your take on it? Because when I work with children and provide counseling, I come across their status messages. And it just, I see them as a cry for help. But when you call it, it's a completely different story. So just wanted to know your perspective on that.
Like this, generally either social media or status. Sometimes you come across this kind of messages when social media content and post also do give some underlying messages about mood issues and about other things. But sometimes it's like become a peer learning also. So they may not have significant psychiatric issue, but they say this is the time for me to post particular thing which somewhere so that other people come to know. But even if, but that's not, I would say this is one expression of their mood state. If other people can pick it up. But the ideal method always would be if they are under distress, they should be encouraged to communicate with anybody whomsoever they confide in. But these have become the red signals to address it, because sometimes they will be false positive, but we have to see that it false positive. They may be genuine cases also.
Sometimes we conflict and dishonest within the person also, that's why I just
possible. But there's always individual variations.
Thank you.
The cut-paste messages can create a problem also.
Yeah.
Including the status.
Yes. Last
question. Yeah, sorry. Hi, my name is Rajiv and I work with an alliance called Family for Every Child. My question is to Siddharth, a couple of questions actually, if I'm permitted. So when you when you collect the data, analyze the data of the calls that are incoming to your helpline, apart from boys and girls, is there any way you desegregate the data? For example, rural and urban, like in the other slide that you mentioned about the gap, and children with disability. For example, deaf children who have that, who want to communicate, but because that their surroundings are not supporting their communication or way of communication, so they they have a tendency to go online. Okay, and there there is a trap. Okay, so I don't know what is there in terms of that analysis. That's one. Two is very important. So you have built a technology. What are the safeguarding mechanisms that are inbuilt into that technology? Because again, it's a technology which is exploiting the children and putting them in danger. So in your technology, what kind of safeguarding measures that you have undertaken? The data that you are gathering, how you are safeguarding that data. And the last point is about the so-called perpetrator. I'm saying so-called perpetrator because in our work, we have identified that most of the children are actually displaying behaviors which are either problematic or harmful to themselves as well as to the society. So we kind of differ from the word perpetrated label to them. So therefore, is there any way that you engage with those children who are displaying those problematic or harmful behaviors?
So do we get urban rural data? So see, one of the, actually your first and the second question are sort of tied in together. So as a security practice, we only take in that much information as is required for us to process the case. So sometimes when children come in, they don't even want to reveal their name. We work with a lot of pseudonyms. Like state information they give, but specific information, unless it is relevant to the case, we don't actively seek also, they don't give also. So we may not really have urban-rural data, we may have district data. But that's how granular we are. In terms of like your second question, which is, sorry, what was your second? Safeguarding, yeah. So basically, yes. So what we did is, so we basically Meta put us in touch with a company called Tech Matters. Tech Matters builds backends for childlines across the world. So they were building backend for Childline South Africa, Childline Zimbabwe, etc. And they put us in touch with us. We got a securities expert who works from the private sector, who was willing to volunteer for us, because that level of security, I don't think even I have the expertise to do this. So at the backend and at the technology level, it happened between two of them, and it was vetted by a lawyer. So that's the process we followed. But now what exactly it goes in, I don't know. But in terms of like security measures that we put in, where it's like under 18, we always file at least a cybercrime.gov.org. If the severity of the crime is high, we make sure there is an intimation to, like, like any sort of relevant authority. We work very much in the system, because I also understand the system is also paranoid about us handling these cases coming to us. So we are mindful of that. And we also look at, and we've also worked on child sexual abuse. So I think, sorry, are we running out of time? Okay. I have one last question. Okay. So in terms of like confidentiality, anonymity, etc., like, we follow those that we anyway follow in our casework. Other than that, the third question, which was the perpetrator, yeah. So see, when we started this 6 months ago, on a test case, we started talking to a couple of perpetrators. Now, what has happened is, initially when he listened to us, he backed off. Okay. Now then, when there is no consequence, he comes back with. Now you must have also observed this on the ground, where police catches a perpetrator, takes him in, and then releases him. He gets more confident. So he started harassing the girl. Okay, now you went to these guys, even these guys didn't help you, and this happened in 2 cases. So now we've decided to stop working with the perpetrator. We haven't closed the option. We are waiting for a case to come where the perpetrator is based in Mumbai. So at least we are there on the ground, then let's see how this works. But this is very much work in progress, talking and reasoning or restoring stuff with the perpetrator.
Okay, sorry. One point on, not a question. What I felt that, going through the content which is available online for children, which is mostly consumed by children, the content creators are, not held responsible. For example, if a child, like you mentioned, what is the information that children look for? If before the exams, for example, if they want to have some online tutor, the tutor who is providing tuition online without any, affiliation or any accreditation or anything, what happens is sometimes that information may not be the correct information. So just before the exams, what I found among the children who were involving in the board exams, appearing for the board exams, they were, visiting different websites and which were giving different types of answers to the same question. So it was, instead of helping, it was creating lots of confusion, misleading and misconception about many topics and concepts for the children. So I think, like, Kannan sir, you mentioned that, we are a consumer, so we should be, more, rational about consuming what we want. But for children, I think, it's important the content has to be verified, also approved, or, before it goes to the public, there should be some regulatory mechanism to control the, information, which is being given or, provided freely to the children. We have also, experienced that a lot of information about mental health, about children, about sex and sexuality is given by some professionals. And they are presented in a manner that, this is correct. Only thing is, this is the correct, you don't have to go to anywhere. So, for their, increasing their viewers or their whatever they are called consumers, they present the matter in a manner which is attractive for the children, but they are not correct. So being popular among the children, people are creating a lot of information on the topics and subjects which are children look for, like sex and sexuality, but they are being created by some trained counselors. They give their identities also. Like, for example, I'm a doctor, pass out from this premier institution. So even parents also believe them. But if you go to their content, it is so ridiculous and misleading, confusing, and also children get into trouble because of that.
Thank you for your observation. Thank you for your observations. And with these comments, I think we conclude this panel discussion. And we thank all my colleagues for their contributions and as well as for your participation in this. Thank you.
Thank you, Dr. Manoj Kumar Sharma sir, Kanan Krishna Swami sir, Siddharth sir, and Ambika ma'am, for such an enriching. Yes, please.
I just want to say that the session is not over yet. This session is over, but we have our mime artists coming in. So please don't leave the hall. Your tea will not be served till you watch the mime show, okay? So we have told them not to serve the tea till you watch this, okay? So thank you.
Okay. Thank you, ma'am. Actually, I was about to say these lines only, that we have a special mime performance by our children. And that is why I would request if the front row, 4 rows we need to clear. Yes. I would request all our guests to please move back 4 rows, because we need a bit space for the performance. Ma'am, your phone is there.
I just, when everybody settles down, if
I would request all the guests, please do not leave this hall. Please be seated inside only, because our children are waiting since, I think, past 30 minutes for us only. Please be seated in the hall itself. Yes. Yes.
if everybody is in, oh God, this is falling off. It's falling. I just wanted to say, if everybody is in, can you just switch off the music for a moment, please? Yeah, thank you so much. I just wanted to tell everybody who is here that this is a group of our children they're children from one of our contact points. All of them go to formal schools, government formal schools. But they're also part of our theater and other programs of ours. They're part of our cooperatives. And so when these children, in our interaction with them about mobile and technology, they decided to come up with a street play, which is a mime on mobile and excess use of mobile. And they have performed this in different places. The last time they performed was in the Supreme Court judges, in front of the Supreme Court judges and the State High Court judges. They performed this mime show. So when we spoke to them that we are having this international conference on mental health, and that one of the sessions is going to be on technology, and on social media and the excess use of mobile. As I can see, Dr. Shekhar Sheshadri is on his mobile, and now the kids will put their mime show to tell us that what we do with our mobiles. Okay, thank you very much. Please.
थैंक यू बच्चों, बहुत ही मनोरंजक परफॉर्मेंस था आपका, बहुत बहुत अच्छा लगा हमें, वेरी वेरी लाइक वी रियली अप्रिशिएट कि आपने इतने अच्छे से प्रिपेयर किया और आज इतना अच्छे से आपने परफॉर्म किया। इसीलिए मैं हर एक जन को मास्टर रोहित ठाकुर, मास्टर रोहित कुमार, मिस टीनू कुमारी, मास्टर हिमांशु, मास्टर ऋतिक, मिस भारती, मास्टर आकाश कुमार को तहे दिल से धन्यवाद कहना चाहती हूँ। अच्छा, so now we can all proceed for our tea, and it's waiting for you. Please proceed towards the hallway. Thank you so much. We'll meet again tomorrow for our third day, and that is our last day of this international conference. We would like to meet you all, if possible, by 9:45 a.m. at least. Thank you. सारे स्पीकर्स को देना, जो है अंबिका पंत को दीजिए, कनक स्वामी, सिद्धार्थ पिल्ले और मनोज कुमार शर्मा। हाँ, मनोज कुमार शर्मा सर को दे दिया आपने।